All right, so we are going to look at nursing care plan. Okay, and I'm going to take you through some processes that can help you to master the nursing care plan. In fact, you know very well, nursing care plan, it's developed using the nursing process approach or using the nursing process. Okay, and like I said earlier on, nursing process is basically a systematic, patient-centered, goal-oriented method of caring that provides a framework for nursing practice. Okay, so when we say nursing process, it's a systematic way of providing care for patients. Okay, a systematic way, meaning it goes through a certain process. It goes through a certain order. If you say something is systematic, it goes through certain order or it goes through a certain process. That is why in nursing, sometimes a patient will come with a certain problem. You just don't begin and then you are just caring for the patient. You may have to organize the nursing activities in a certain order. We follow a certain order. That is what makes it systematic. And when we say nursing process is patient-centered, meaning it focuses on the patient. That's the reason why the care you would give to each patient as a nurse should be unique, even if they are having the same problem. Usually the care should be unique. It should center on the patient, meaning when you are administering care to patients, the patient should be at the core, the center of the care that you are administering. And then it should be goal-oriented. If you are caring for a patient, you should have something you want to achieve at the end of the day. You shouldn't just be caring for a patient. You should set goals. Okay? So the nursing process is a systematic, patient-centered, goal-oriented method that provides framework for nursing practice. Now, it involves how many steps? It involves 5 steps. The 5 steps, we have assessment, we have diagnosis, we have planning, we have implementation, and then we have evaluation. We usually use this acronym, ADPI. Okay, ADPI. Is that okay? Good. And we will look at these steps into detail briefly when we move on to the next slides. Now, what are the importance of the nursing process? The importance of the nursing process is to provide holistic and individualized patient care. Okay, holistic and individualized patient care, more like a patient-centered care. You remember I mentioned that nursing process is a systematic, patient-centered, goal-oriented method of caring. Yes. So one of the importance of nursing process is to provide holistic. When we say holistic care is like a care that addresses all the health needs in all facets of the patient's life. So spiritual, emotional, physical, psychological, you get it. Every aspect of the patient's life. That is what makes the nursing process holistic. So as a nurse, if you are caring for a patient, you shouldn't just focus on one aspect of the patient's life. All facets of the patient's life. Physical aspects of the patient's life, physiological, psychological, emotional, spiritual, all aspects of the, and that is what makes it holistic or comprehensive. Okay, so it provides holistic and individualized, meaning patient-centered. Okay, don't always try to impose the knowledge you got from caring for a particular patient to another patient. Maybe patient A was experiencing this problem. You initiated this intervention, so you are going to give the same thing to patient B without doing proper assessment. No, individualized care. Okay, so nursing process ensures that the physical, emotional, social, and spiritual needs of each patient are addressed, leading to what? Comprehensive and personalized care. Okay, that is the same as patient-centered or individualized care. Nursing process also promotes continuity of care, and you agree with me because nursing process is like a way of communicating between nurses. So it provides or promotes continuity of care, because if I'm on the ward as a staff and I'm using nursing process to care for a patient, okay, whatever level that I get to, if another nurse comes and start reading what I've done, the person will have an idea of the patient's problems. The person will have an idea or an understanding of the patient health history, and that person would also be able to carry on with the rest of the care. Okay, so the person wouldn't have to go and start all over again. So the nursing process actually promotes continuity of care. For this point, you can also say that the nursing process also facilitates communication between health workers, especially nurses. Nursing process also enhances critical thinking and clinical judgment. Because see, the nursing process, one of the steps in the nursing process is diagnose. Before you can properly diagnose a patient, okay, you should be able to give a very reasonable or good clinical judgment. That is why we say nursing process, because you do diagnosis. And if your clinical judgment is not good, you can't do proper diagnosis in nursing process. Is that okay? Critical thinking, before you can set a reasonable goal, a goal that is attainable, a goal that is achievable, okay, you should be able to think critically as a nurse before you be able to prioritize the patient's health problems and know that this problem supersedes this problem. This problem have to be addressed first before this. You should be able to think critically. Okay, so the nursing process actually enhances nursing or nurses' critical thinking and clinical judgment, which I believe you all agree. Because see, as a nurse, you are expected to assess the patient's health problems, patient's data. You are expected to make informed decisions. You are expected to evaluate the health outcomes of the patient. You are supposed to be a problem solver, and you are supposed to make decisions. Sometimes you have to prioritize the patient problems and decide which one to carry on. Okay, good. So nursing process makes we nurse. So for example, if you are doing nursing care plan, you realize how you think critically. Yes, so it enhances your critical thinking skills. The nursing process. The last but not the least is it improves patient outcomes. Once you are using nursing process to care for a patient, definitely the patient's health outcomes will improve. You'll be able to achieve something positive. Okay, and the last one is it provides a legal and professional framework. Now, some of you may not appreciate this point until you are faced with a legal issue. Okay, and this is why document and nursing process, you can't do proper nursing process without documentation. That's why we do the nursing care plan. So nursing care plan is like the documentation part of the nursing process. The nursing process is like a system on its own, but the nursing care plan is when we are putting the nursing process on a paper. When you now decide that, okay, I'm going to care for a patient using nursing process, this time I'm putting it on paper. That is nursing care plan. Okay, and it serves as a tool, a legal and professional framework. Okay, so that when it happens that there are legal issues regarding the patient's care, they can quickly pull out the nursing process document. Okay, so that they know, okay, this is what the nurse did for the patient. These were the problems the nurse identified. Do you get it? If you are faced with a legal issue, the nursing care plan or the nursing process. And so these importance of nursing process, these are the same importance of nursing care plan. If you are asked the importance of nursing care plan, this is the same thing you are going to talk about. Okay, so we mentioned that the nursing process is patient-centered and holistic care. You see, patients is at the core. You see the nursing process. You see, patients is at the center of the nursing process. Okay, so the nurse, you honor the choice of the patient. You promote respect. Okay, you empower recipients of care, which is the patient, and you improve quality of life. So once you are caring for a patient, you have patients at the center of the core. You are able to support the patient's independence. Your focus will be on the fact that you want to care for the patient to become independent. Okay, you also promote positive well-being. Okay, you promote positive well-being. Is that okay? Good. And these are the 5 areas of holistic care. What are the areas? Social life, the mental health, social health, mental health, emotional health, physical health, and then spiritual health. These are the 5 areas of holistic health care. Okay, so as a nurse, in nursing process, you do holistic care or comprehensive care. And comprehensive or holistic care is a care that does not look at only the patient's physical life. but you look the physical health, you look at emotional health, you look at social health, mental health, and spiritual health. Okay, so you see patients is at the center of the care here. So the pharmacist is here, the specialist, the lab technician, the doctor, and the nurse. Then the patient is at the center of the care. Okay, now the steps in the nursing process, the acronym is ADPI. The nursing process has how many steps? 5 steps: assessment, diagnosis, planning, implementation, and then evaluation. Okay, when we say assessment, assessment has got to do with you collecting data from the patient. You are collecting data. Okay, you are collecting data. What kind of data do you collect? The age of the patient, the sex of the patient, the religion of the patient, where does the patient stay, the address of the patient, is the patient having any past medical history, a patient's present medical history, what are the patient's complaints? Okay, do you perform assessments? Are there any abnormalities that you identify physically during the assessment? All those things comes under assessment. What are the patient health problems? What are the patient's family strengths? All those things, you get them during the assessment. In fact, that is the main purpose of assessment, including even the patient's laboratory investigations. Okay, now under assessment, one thing you should notice that there are some informations that only the patient can give you. Okay, those informations, we call them subjective data. There are some range of informations you can never get them as a nurse through your observation or your techniques. Only patients can give you those information. We call them patients reported data or subjective data. Okay, for example, if a patient is in pain, okay, unless patient tells you, you can't know. Another example is the hometown of a patient. If a patient don't tell you the hometown, you wouldn't know. Okay, if the patient don't tell you whether he's married or not, you wouldn't know. If the patient don't tell you he has been admitted before, you wouldn't know. So any kind of information, the patient have to be the one to tell you. Patients reported. Patients have to tell you before you get to know. They are subjective data. Okay, and the ones that you, the nurse, you can observe. You can get to know without patient telling you. For example, if patient is having rashes on the face, on the skin around the face, you can see it just by observation. So that one is observable data or subjective data. Sorry, objective data. Observable data or objective data. Okay, for example, vital signs. Okay, vital signs, you can check the patient vital signs. It's an objective data or observable data. Okay, now for patient history, the patient's past medical history, if you don't ask patients for patient to report, you may not know. So it's a subjective data. Do you get it? Then we have diagnosis. Diagnosis. Okay, now in nursing care plan, okay, now when we get to this side, we've started care plan proper like that too. And this is the basis. A lot of people have issues with care plan because their foundation at this level is not so good. Okay, so from here going, pay attention and make sure you understand every area that we get to. Okay, good. So the diagnosis, when we say diagnose is basically the problem of a patient related to the cause of the patient. In the nursing process, at the level of the diagnosis, the time that you are trying to clinically judge the patient. Okay, you are judging the patient's problems clinically. Okay, when we say diagnosis is the actual problem the patient is having or the potential problems that the patient is having related to the cause of the problem. That is what we mean by diagnosis in nursing. So when we say nursing diagnose, we are talking about the actual problems of the patient or the potential. When we say actual problems, the problems that are present, you can see. The problems that are present, you can see them. And when we say potential problems or risk problems, these problems, they are not there. But because of certain problems that are present, those problems can occur. We call those problems potential problems. And you get all these problems based on assessment. Now, remember that in nursing diagnose, okay, the diagnosis that you actually decide is just the same as the problem you wrote. the mistake some of you make in the nursing care plan proper is that you don't understand these parts very well. So you see a lot of you writing a problem as in the nursing diagnose and relating it to a problem again. For example, you write a problem like loss of patient's complaints of loss of appetite. Then you write a nursing diagnose that imbalanced nutrition into bracket less than body requirements related to loss of appetite. Forgetting that imbalanced nutrition that you've written is representing the loss of appetite. So you can't relate it to loss of appetite again. So it's like you've done problem related to problem. Okay, so you do it imbalanced nutrition less than body requirements related to maybe disease process. You get, because once you've written loss of appetite as the problem, whatever diagnosis you write, it means that diagnosis actually represents the loss of appetite, because nursing diagnosis is problem related to cause, meaning the first part of the diagnosis is the problem. You get it? When I get there, I will explain all those things. Let's continue. Now, the third step in the nursing process is planning. Okay, planning in nursing process simply talks about setting goals, setting objectives. Okay, setting goals or setting objectives. Under the planning tool, you prioritize. Under the planning, that is when you prioritize the patient problems, or you arrange the patient problems and decide which ones to address them first. Is that okay? That one too comes under planning. Okay, in planning, you set goals and objectives. Now, the key point with the planning is that you should set goals that are SMART: specific, measurable, attainable or achievable, relevant, and then time bound. Okay, so when you are planning, you have to plan having this SMART in mind. You should set goals that are SMART. Is that okay? So planning is when you are looking at the patient problems and you are setting goals that you want to achieve with the care that you intend to initiate. Okay, and we are saying that during the planning, you should be specific. Okay, go straight to the point. Don't set multiple goals for just one problem. Go straight to the point and tell us that this is the objective. Is that okay? And it should be measurable, please. The goal that you set and the planning, it should be measurable. We should be able to measure it. Okay, and that is the reason why you realize that we even have time bound. Don't write an objective without indicating the time frame you want to achieve it. It is wrong. So anytime you write an objective or a goal in nursing, you don't indicate the time frame you want to achieve it. It is wrong. Is that okay? That is one important thing that you need to know. Okay, so under the planning, you should set goals that are measurable, achievable. Do you get it? Good. And then you should prioritize. You should prioritize the patient problem and then prioritize the goals that you want to achieve. Definitely one goal may be very important to achieve as compared to the other. So you should learn how to prioritize during the planning phase. And then implementation. Implementation in the nursing process simply means you are going to carry out the actions that you decided on during the planning. Now, remember that in the nursing care plan, you see we have objectives to outcome criteria and nursing orders. In the nursing process, the objectives to outcome criteria and nursing orders, they come under planning. They all come under planning. Let me repeat this again. In the nursing care plan paper, you see objectives to outcome criteria and the nursing orders. When you are bringing it to the nursing process, the objectives to outcome criteria and the nursing orders, they all come under planning phase during the nursing process. Okay, so it's during the planning phase that you set the goals and objectives. It's during the planning phase that you tell us what you are going to do to achieve the goals that you set during the planning phase. And during the implementation phase is what you are now going to carry out the actions that you listed under the planning, that it will help you to achieve the goals during the implementation phase. So implementation or the intervention phase is more like you are carrying out the steps or the actions Do you get it? You are carrying out. So if it is about monitoring that you are going to give, you are going to do the monitoring. If it is about treatments that you are going to initiate, you are going to give the treatment. If it's about medication you are going to administer, you go and administer the medication. If it is about education, you educate the patient, you go ahead and educate the patient. If it's about reassurance, you are going to reassure, you go ahead and reassure the patient. Then the last phase is the evaluation. Now you've implemented actions. Now you are going back to the patient to go and assess again. Okay, the actions that I implemented, has it helped me to achieve the goal? So it's like you are going to put the patient on a scale again, but this time you are going to put the patient on the scale, having the actions you carried on out in mind. Okay, I mentioned that I'll assess patient vital sign, I'll assess patient's level of pain, I'll employ diversional therapy. I administered prescribed medication. Okay, after doing all this, have the patient's pain reduced? That is evaluation. Okay, so the evaluation phase is when you are trying to, it's like you are doing a revision of the whole process again, because now you've carried out an action, you've implemented something. So you are doing a revision to find out whether all the care that you initiated, it has helped to achieve any of the goals. That is implementation. Sorry, that is evaluation. Okay, that is evaluation. Okay, so like I said, SMART. When you are setting goals in nursing process, it should be SMART. We use the acronym SMART. It should be specific, it should be measurable, it should be achievable, it should be relevant, and then it should be time bound. So that means time bound. You don't set a goal without indicating the time frame. So the goal should have a clearly defined time frame to provide direction and allow for timely evaluation. Because see, if you don't tell us that, you don't mention the time frame, how are we going to know the time you want to evaluate? Okay, so for example, patients would report pain level less than, or patient's level of pain will reduce within, let's say, 30 minutes. Okay, after analgesic administration. This is just an example. We will come to the details and how we write it proper in nursing. Okay, now you realize that we have a time frame. So if I'm to evaluate, I will evaluate after the time frame. I will evaluate after the 1 hour. So if you are setting an objective and you don't specify a time frame, how will you know when you are going to evaluate the objective or evaluate the care you are giving? No, so you have to always state a time frame. So it should be time bound. It should be relevant. Patient is experiencing pain. You are going to set a goal about bed bathing or about self-care. Patients cannot eat without assistance. Then you are going to set a goal to go and ensure or maintain personal hygiene. No. Okay, it should be relevant to the patient's problem. That is the relevant. They are. It should be relevant. It should be something that you should be able to achieve. Now, listen, this thing, if you understand this thing properly, it will help you to set proper goals. Okay, and some of you have issues setting proper goals because your foundation over here is not good. Okay, the goal should be what? Achievable. You don't argue on it. It should be achievable. Whatever goal that you set, we should be able to achieve it. So that means that if you set a goal and at the end of the day you write goal partially met, the goal was not so achievable enough. You always have to try as much as possible to set goals that you can achieve. So if your care plan, you are always writing goal partially met, it means you have a problem with certain objective. You should try as much as possible to always set objectives. So to always set goals that you can achieve, please. Okay, and then the goal should be measurable. Okay, the goal should be measurable. Okay, it should be measurable, and then it should be specific. You should clearly state what you want to achieve. Clearly state it. That this is what I want to achieve. I want the patient pain to reduce. But you are done. It should be specific. Don't write multiple things you want to see within one goal. No, it should be specific. One. That's why if you are writing objective and outcome criteria, you see just one focus. You get it? Good. Now, the nursing care plan proper itself. You've started the business again. The nursing care plan proper. Okay, like I said, nursing care plan is not different from nursing process. Nursing care plan is just a document. Okay, it's like a written guide, or it's like a map, or it's like a structured or a written guide that is telling us how you intend to care for patients using the nursing process approach. Okay, so nursing care plan is like a roadmap, or it's like a written document. But in that written document, it's a written document describing all the processes you intend to go through to care for a patient. Just that it uses the nursing process. Is that okay? It uses the nursing process. Is that okay? Good. It's just like case study. You know, case study is also a written document that is submitted. It's like a report that is submitted. But in case study actually narrates the process that you went through in caring for a patient. Okay, from time of admission to the time of discharge, using the nursing process approach. Okay, so if you read the preface of your case study, you are going to see description of the nursing process approach there. Most of the time, most of you copy. But go back and go and read. You see that it's talking about the nursing process approach, because that document, you made use of nursing process approach to come up with that document. Is that okay? Good. So the nursing care plan is like, it's like a written guide that is developed by nurses to outline the individualized care and treatments that a patient needs. Is that okay? So you are writing something down, you are stating the problems of the patient, the objective of the patient, and then the treatments or intervention you think the patient will need. So the nursing care plan is just a document, but in coming up with that document, you use the nursing process approach. So it's like a roadmap. So when we come and you are caring for patients, you've used the nursing care plan. We will just come and watch what you are doing and continue with the care. So it's like a roadmap. It's guiding us on what to do. Okay, these patients, these are the problems. This is what has been done. Okay, these problems was identified. Nothing has not been done. Let's continue. Let's continue with the problem. Okay, so nursing care plan is like a document. And I mentioned that the importance of nursing care plan is just the same as the importance of nursing process approach. It promotes holistic and individualized care. It enhances communication among care teams. And I mentioned this. It ensures continuity and quality of care. It facilitates patient-centered decision-making. And it promotes basis for documentation and legal accountability. Now, the components of the nursing care plan. Okay, these are the various components that if you have a nursing care plan, you see all these components on the nursing care plan. We have an aspect of the nursing care plan purposely for assessment. Okay, especially the front page, this front page of the care plan here. Okay, this area, like the personal data. Okay, the personal data, all the things that you are writing there is just for the purpose of assessment. So the name of the patient, the inpatient number, the age of the patient, the past medical history, the present medical history, the laboratory investigations, the diagnosis of the patient, all these things are under assessment. Okay, good. The allergies, also assessments, the allergies. And even the patient problem and patient strengths. If you don't do assessments, you can't get patient problem and patient strengths. Remember, assessments can also include just observation. Is that okay? Now, the things that you write here, all these things are part of the assessment. So the routine care, all these parts falls under the assessment in the nursing process. Then the medical orders, all these things falls under assessments. So the medical orders, the medication that the patient is taking. Okay, good. Are there any other treatments that has been performed for the patients, and then the investigations? All these things comes under assessment. Okay, so the components of the nursing care plan, we have the first component, which is assessment. The assessment basically is collecting data from the patients. And remember, we mentioned that data can be subjective, and then some can also be objective. Okay, and the whole care plan begins from here, the assessment. The whole care plan begins from the assessment. Then we have the nursing diagnosis, like I explained earlier. Nursing diagnosis is the clinical judgment about patients' responses to actual or potential health problems. And in the nursing diagnosis, we have nursing diagnosis problem related to cause, the problem of the patient related to the cause of the problem. Now, remember that the problem can be an actual problem, meaning a problem that is present. And the problem can be a potential problem, meaning a problem that is not present. But because of one or two situations, the patient can end up in those problems. Is that okay? Those ones are potential problems or risk problems. A practical example of a nursing diagnosis: acute pain related to what? Surgical incision. So that means that this acute pain is representing a certain problem the patient is having. The problem is patient complaints of lower abdominal pain. You get it? So this first part of the nursing process is representing the problem that you've written. Is that okay? This one, the acute pain, into bracket, lower abdomen, is representing the problem that you've written under the patient's problem. The first part of the nursing diagnosis. And then the second part is what caused that problem. Okay, so the nursing diagnosis is the problem related to the cause of the patient problem. Now, objective stroke outcome criteria is just the same as the objective stroke outcome criteria that we've done. The key thing is the objective stroke outcome, the objective should be what? Smart. Okay, objectives should be smart. And I told you that if you come to the nursing care plan, the objective stroke outcome criteria and then the nursing orders, if you take it to the nursing process, they all fall under planning. If you take this one from the nursing care plan, the objective stroke outcome criteria and the nursing orders, if you take it to the nursing process approach, they all fall under the planning. Okay, in nursing process, the planning is when you are setting the goals, what you want to achieve based on the problem the patient is having, and then how you intend to achieve them. Okay, now the moment you start carrying out the actions that you planned, then you are doing implementation, and implementation is also a resemblance of nursing intervention in the nursing care plan. Do you get it? Good. And then the last one is the evaluation. So now let's look at the objective. Look at this objective. Patient's lower abdominal pain will reduce within 50 minutes, as evidenced by patient verbalizing that pain has reduced and nurse observing patients with a cheerful facial expression. Okay, you see, the goal or the objective is very specific. What do I want to achieve? Patient's lower abdominal pain will reduce. You see, it is specific. I didn't say patient's pain. I was specific. What pain? Patient's lower abdominal pain. That is what we mean by SMART. Your goal should always be specific. Patient's lower abdominal pain. Straight, specific. So whoever looks at it knows which pain I want to reduce. The lower abdominal pain. Within 50 minutes, as evidenced by nurse verbalizing that pain has reduced. Okay, you see, I've stated the time frame. See, 50 minutes. So that means that immediately after 50 minutes, I'll go and do evaluation. 50 minutes. Okay, so your objective, if you write an objective, you don't have a time frame in it, please. There is a problem with the objective. Okay, now the nursing order, for example, nursing order is like a commando. It's like a directive. It's like you are giving someone an instruction. Okay, so if someone is reading your nursing order, it should be like you are commanding or instructing the person. Look at the language. Assess patient's level of pain using pain assessment scale 0 to 10. Now, the error a lot of students commit over here, they write it like they are writing a proposal. It's not a proposal. It's a command. It's an instruction. It's a directive. Don't write, I will assess patient's level of pain. No, it's not a proposal. It's an order. Okay, so instead of write, I will assess patient's level of pain, it's like you are giving an instruction. Okay, so be careful with the language, how you choose the language when you are talking about this side. Okay, so assess patient's level of pain using pain assessment scale 0 to 10. Is that okay? Then if you are intervening, then you convert it into pass. Patient's level of pain was assessed using a pain assessment scale 0 to 10, and he ticked 7. You see, and he ticked 7. Now, evaluation. We've done evaluation already. Evaluation is when you are looking at the patient's objective, cross-checking it against the intervention to see whether you've achieved the goals and objectives that you set. Okay? So, usually in nursing care plan, we use goal fully met as patient verbalize that pain has reduced and nurse observe patients with a cheerful facial expression. Goal fully met as patient verbalize that pain has reduced and nurse observe patients with a cheerful facial expression. Now let's begin with care plan proper. Now, this
Sir,
is how yes, please, Peter. Honorable Peter, ask your question.
sir, please, where you said the patient take 7,
Okay.
so does it mean the 7, is it meaning the pain was high or what?
Good. So 7 on a scale of 0 to 10, 0 means no pain. Okay. 5 will mean middle pain or moderate pain, and then 10 will mean high level of pain. So if patient takes 7, meaning patient's pain is slightly above moderate. So that means patient is actually in pain. Do you get it? That means patient is moderately in pain. Okay, so this is part of the orders that you set when your patient is having pain. Assess patient's level of pain. So you see within the orders, we didn't write what patient taked, but under the intervention, we've indicated that patient takes 7, meaning the action has actually been done. Okay, patient's level of pain was assessed. Look at the language, assessed, past tense, using a pain assessment scale 0 to 10, and he takes 7, meaning the action has indeed been carried on. So intervention is like you are writing it in a way that the thing has been done. The action that you stated in the orders, it has been carried out. For example, set a trolley for bed bathing. In intervention, a trolley was set for bed bathing. Administer prescribed analgesic. Under intervention, prescribed analgesic, tablet paracetamol 1 gram was administered. Okay, so the intervention is you are letting us know that the action has been done. So you write everything in past tense and indicate or mention some parameters to let us know that the action has been done. Check patient vital signs, temperature, pulse, respiration, and blood pressure. Patient vital signs, temperature, pulse, respiration, and blood pressure were checked and recorded. You are writing it in a way for us to know that the action has been carried out. Is that okay? Please, are we good? Are we good? Today, ask all your questions. Today's lesson is going to be very extensive. I'm going to address every issue relating to practical, relating to nursing care plan, relating to care study, everything. So all the questions you have on these areas, put all of them down. Okay, so that when
Sir,
I finish, I'll just, yes, please. Peter, go ahead. I'm
sir,
listening.
per my understanding,
Okay.
the 7, since we've done the thing for the patients and we take
Okay.
7, I see
Okay.
it as still we've not achieved our goal because
Good.
the
Do you
7.
know that? Do you know that when you are setting the objective, this doesn't mean you've not achieved. Do you know when you are writing the orders for a patient with pain, you first of all have to either reassure or assess. Okay, in the first assessment, you write assess patient's level of pain using a scale of 0 to 10. Okay, then intervention, patient's level of pain using a scale of 0 to 10, patient takes 7. Then you now come in with your intervention. Administer prescribe analgesic, employ diversional therapy, check vital signs. Now you can bring another order, reassess patient's level of pain. Do you get it? Because in your orders, if you didn't assess, how did you know patient is in pain? In your orders, if you initially didn't assess, how will you know patient was in pain and you want to reduce the pain? Are you getting it? So in pain orders, you can have another point, reassess. Do you get it? Reassess patient's level of pain. I'll come to all that. Okay, reassess patient's level of pain. But I usually consider students who write it that way to be smart. But fine, Peter, instead of writing reassess, maybe you don't want to write the assessment twice. Because the others, you are even expected to just write 3. But I always advise students write 4. Maybe you don't want to write first assessment and come and write another assessment again. So you just want to go straight. Then you can write assess patient's level of pain using a scale of 0 to 10. Using a scale of 0 to 10 for the others. Then the intervention, patient's level of pain was assessed using a scale of 0 to 10. Patient take, let's say, 4. Or patient take 3. And that will mean that the pain has reduced. Do you get it? So it means that in your case, Your assessment is not assessing the pain, the existence of the pain. You are rather assessing the implementation that has been made. So you can't write that assessment first. It means that in writing your points, the orders, you should go and put that assessment even under the medications. Are you getting the point? This is what we are
Yes.
talking about here. Look at this. This is the problem for pain. This is how it looks like. Look, this is it. You see, reassure patients that measures will be taken to reduce pain, not relieve, reduce pain. Now, assess patient's level of pain using a scale of 0 to 10. Okay, patient's level of pain was assessed using a scale of 0 to 10. Patient take out 7. You see over here, this order came at a time we've not initiated any sub order. Can you see that? You see the position of where the order is. Can you see? Can you see
Yes,
the
sir.
position of where the order is? Good. That is why we mentioned that during plan, remember that the nursing order is under planning. No? And that is why when you are writing nursing orders, you have to prioritize it. Okay, so now see, if you want to write that patient's level of pain was assessed using a scale of 0 to 10, patient take, let's say, 2, then it means that that order can't come here in front. It should rather come to, let's say, even after the administer prescribe analgesic. Have you gotten it? It should come under this so that you write assess patient's level of pain using a scale of 0 to 10. Then patient's level of pain was assessed using a scale of 0 to 10. Patient take 2. And that will be understandable because you've already implemented some orders before that assessment. Peter, have you gotten it?
Yes, sir. Yes,
Good.
sir.
Usually what students write is that they will write first assessment, then after they administer prescribed medication, they write a last one, reassess patient's level of pain. Then that one they will write, patient's level of pain was reassessed using a scale of 0 to 10. Patient take 2. So everybody reading will know that the first assessment, patient takes 7. The second assessment, now patient take 2, meaning pain has reduced. Do you agree to that? Have you
So
gotten it?
I've gotten the 2 points.
All right, that is it. So that is it. We've not gotten there yet. Okay, good. So this is the entire nursing care plan, referencing Nursing and Midwifery Council. This is how the nursing care plan looks like. So we have a point that assess the patient. So the area that assess the patient, we have the personal data, we have the patient and family health problems, we have the allergies, we have the patient and family strengths, we have the routine care. We have the patient's medical records, 2 marks, the medications, the other treatments, the investigations. That will give you 2 marks. This is at the back of the nursing care plan. And then we have the care plan proper itself, 12 marks. Okay, 12 marks. Now let's look at more details. Now, this is the inside of the care plan. This is how it looks like. The inside of the nursing care plan. Okay, over the week, I've been assessing some students' nursing care plan, and I've been marking about 100 nursing care plans during this week. And you'll be surprised that even after students are being taught, students are still committing errors. The errors where they still write the patient's strengths, and I know even some of you, if care is not taken, you will still go the practicals and still go and commit the error. Sometimes I get surprised. You've taught the thing the right thing to do to save the person from error. They will go and do something else thinking they can overcome it. By the time you realize they were there, and all of them, they'll be like, say, you said it, you said it, we forget. You get it? There are simple instructions. So if you don't follow it, by the time you realize you commit the mistake, you not even realize it. Is that okay? Good. And some of them may not even be lucky to even identify that they've written the patient's strengths under the allergies. They may not realize it. Okay, some are able to realize it and cancel, but some are also not able to realize it. Okay, so please be very careful. So this is how the inside of the care plan looks like. So the nursing diagnose, if you write it properly, you get 1 mark. In fact, I advise that the moment they give you the care plan, let's begin straight. The moment they give you the care plan, write your name, your index number, and sign. So this, the first thing you write, please follow the system that I'm taking you through. I'm pleading with you. Now, I'm not just taking you through this structure just for the fact that it will help you to finish in time. Okay. One, the first focus is for you to finish the care plan in a space of 20 minutes. And another focus is for you to minimize errors. Some simple errors students commit, for you not to be part of those errors. Okay. Now, the first thing you write is the candidate index number, and then you sign. Once they give you the care plan, the first thing to write, the candidate index number, and then you sign. The index number and signature. Now, listen, after writing the index number and signature, come straight to this side, the allergies, and write no known allergies. Please and please follow this instruction. Your first thing you write is candidate index number and then candidate signature. Candidate index number and then candidate signature. Now, the next thing you go and write after that is no known allergies. No known allergies. The reason is because if 10 students you do care plan, 5 of them will write patient strength there. And most of you have committed that error. And if you are not careful, you end up committing that error again in licensing exams. The simplest way to overcome that is after writing your index number. In fact, there is no problem even if you decide to write that one first, at least to take yourself from that percentage of students, please, who commit that error. Because in licensing care plan, you only have access to just one stamped care plan. They won't change it for you like you do during mock exams. They will not change it for you. You have access to one attempt, one nursing care plan sheet. Okay, so you write no known allergies in capital like this, no known allergies. Now, the care plan, you start writing things you don't think first. Now, from the no known allergies, go straight to this part of the care plan, the lower part of the care plan, the front page, the lower part. So from the no known allergies, come straight to this side. TPR, write for hourly. BP, write for hourly. The diet is either you write normal diet or special diet. So the diet is either you write normal diet or special diet. Okay. Peter, when do you write normal diet? Yes. Who remember? When do we write normal diet? Yes. When do we write normal diet for a patient?
When the patient is on this normal food that we eat.
Yes. So patient is able to eat orally. Patient is able to eat normal foods orally, no restriction, not on any external feeding device. You write normal diet. So like all of us, you are able to eat normally. You write normal diet. Okay, when do we write special diet? Yes, when do we write special diet? When do we write special diet?
So when the person is on NG tube.
When the patient is on NG tube, or when the patient is having a condition where the doctor have actually prescribed some restricted foods. So for example, patient is a diabetic patient. There is actually a dietitian who have actually prescribed some specific foods. Then that one we can write special diet. For example, if a patient is on NG tube, you know the dietitian will definitely prescribe liquid diet. But fine, instead of writing the liquid diet, I prefer that you write special diet. Once you are able to find out that the patient is on a certain dietary restriction, write special diet. Now, you shouldn't make any attempt to search. If a patient is on a special diet, it should be easily accessible. If it is not easily accessible, write normal diet for the patient. Because by the time you waste time to go and even find, some of you have not even seen a dietitian prescription or a dietitian referral form before. Okay, so if the indicators are not clear and simple for you to find out that patient is on a special diet, please write normal diet. Once patient can eat through the mouth, I advise you write normal diet. Once you find out that patient can eat through the mouth, please write normal diet. Don't go and say patient is having diabetes. Because of that, I'm writing diabetic diet. Patient is having renal failure, so because of that, I'm going to write a certain diet. Patient is having hypertension, so because of that, I'm going to write low salt diet. Once the patient can eat through the mouth, write normal diet, please. Now, the fluids, we write either liberal fluids or intravenous fluids. When do we write liberal fluids? Who have an idea? When do we write liberal fluids?
When patients can tolerate maybe juice or water.
So patients can tolerate drinks, juice, water. There are no restrictions. That is through the mouth. And even if patients can take fluid through NG tube, it's still liberal fluids. So if patient is on NG tube and it still allow water, the physicians still allow water to be served through the NG tube, it's still liberal fluids. So the fluids is two things, either liberal fluids or intravenous fluids, or you can have liberal fluids and intravenous fluids. When do we write intravenous fluids? Yes, when do we write intravenous fluids?
Sir, for unconscious patients. So
No, I disagree with you. That is not the parameter we use to write intravenous fluids.
When
Sure.
patients takes intravenous, maybe infusions or IV
Yes, so when the
medication.
patient is on IV infusion, okay, you can have an unconscious patient who is on NG tube that we are giving liberal fluids. So we don't use unconsciousness as a parameter to determine that patient is on infusion. You get it? Yes. So when patient is actually on IV fluids, how will you know patient is on IV fluids? What did I say about that? How will you know patient is on IV fluids? What did I say about that? Yes. How will you know patient is on IV fluids or intravenous fluids? What did I say about that? What do you check? Yes, what do you check to know that patient is on intravenous fluids? Oh, let's be fast. As a nurse, if you go to the ward, you want to be sure patient is on intravenous fluids. What do you check? Oh, so
Maybe
you
you can
people
check
are
the
the
fluid
nurses.
chart, the
You people
intake.
are the nurses that
The
if
intake.
you want to check patient is on IV fluids, you check the container. No. If you want to find out a patient is even on a medication, we don't check patient container. You check the intake and output chart. Even if the medication is hanged and they are infusing, patient is not taking it until you've confirmed from the treatment sheet. So there are two ways you use to confirm whether patient is on. Even if it is hanged there in the patient, in nursing, patient is not on it until you see it in the treatment sheet and then the intake and output chart. Someone will ask that, say, okay, what if the nurse have hanged it? They've not finished giving, so they've not written it in the intake and output. It will be in the treatment sheet. If the person is a good nurse, the infusion should be charted on the treatment sheet that it has been administered. Then when you finish administering, now you record it in the intake and output. Yeah, and that is how we check. Okay, so you use the current records on the intake and output chart to determine. So if you have the patient papers and you freight through, maybe you are doing the exams, let's say 20th, 28th, you check. And the night nurses have even given normal saline that's done. It tells you patient is on IV fluids. That is a serious confirmation patient is on IV fluids. You get it? So you check. Rangers lactate, 6 a.m. It tells you that day of the exams, or even a day before. It tells you, or even 2 days ago. It tells you patient is on IV fluids. So that one you can write liberal fluids and intravenous fluid. That is if patient is on both. You can have a situation where patient is on only intravenous fluids, usually post-op cases. Okay, usually post-op cases, immediate post-op cases that their patient is on nail per os, and sometimes pre-op cases that patients are put on nail per os or fasted prior to the surgery. Is that okay? Please, are we good? Are we good? Are we good?
Yes,
Any question
sir.
on the fluids? Okay, so now I believe you've all gotten the fluids. Now the intake and output. Please, the intake and output all the time. These are the only two things you can write. Either monitored or strictly monitored. Under no circumstance should you write not monitored. Now, listen. Over here, there is no place we write not applicable. Please. There is no space under the routine care we write not applicable. Never. We don't write not applicable anywhere on this routine care. Okay, so intake and output is either you are writing monitored or strictly monitored. There is no patient that intake and output shouldn't be monitored though. Go back and go and check your case study, your admission note, or go and check how we write admission report. Go and check the papers for admission. Intake and output is a mandatory paper that you add to your document as a nurse when you are admitting any patient in a hospital. So the intake and output all the time is either you are writing monitored or strictly monitored. The advice I will give you is that all the time you write monitored. Okay, fine. If you are able to update yourself to understand that there are some conditions that we write strictly monitored, that is brilliant. Conditions like renal failure, conditions like heart failure, conditions like hypertension, conditions like nephrotic syndrome. Okay, there are some conditions that you may have to, like unconscious patients on catheter. Those cases or post-op cases, patients are surgical wards. Sometimes you have to write strictly monitored. Okay, but please, all the time, you whether strictly monitored or monitored, the thing is monitored. Even if you write strictly monitored, it's still monitored. Okay, so all the time you write monitored. Okay, you write monitored. Don't stress yourself to even go and write strictly monitored. Okay, good. But I want you to know the dimensions of the things you can write over there. So monitored or strictly monitored. Never write not monitored. Hey, all condition wants you monitor intake and output. No, can you mention a condition? There is no condition you can monitor. You are not supposed to monitor intake and output. Yes, that we don't do the right thing on the ward. We are doing the right thing. Every patient, you have to be monitoring intake and output. The oral hygiene, what do we write there? Twice daily. Bathing twice daily. Sometimes over here, this is what you are supposed to write, but some people can add certain things. They are not wrong too. Twice daily with Pepsodent and Pepsodent toothbrush and paste. Okay, sometimes some people add certain things to it, but it's not necessary. You can also add it and you are not wrong. Is that okay? Good, but we are dealing with time. If you can write a whole essay over here, you still get half. You can write a whole 1 minute essay to waste your time. You still get the same half for all the points over here. Okay. The bathing to twice daily. Now the urine testing, write down on admission. If you have access to the results, you can add it to it, but don't waste time. The body weight, write down on admission. In fact, over here, just write down on admission, down on admission. If you have access to the patient weight, don't make any attempt to waste time to search for it. If it is easily accessible, you can write. But if it is not easily accessible, write down on admission, you are done. Activity, what do we write at the activity? Either active or passive. Now, how did I define active patients? Who remember? How did I define active patients? Yes, how did I define active patients?
So you said a patient who can get up on bed,
Okay.
brush his or her teeth without assistance,
Okay.
bath without assistance, they are
Okay.
active.
Yes, a patient who can turn left, turn right. That is the first condition. Patient who can turn right, turn left without your assistance. A patient who can sit without your assistance. A patient who can even eat without your assistance. Who can get out of bed without your assistance. Who can sit in bed without your assistance. That patient is an active patient. Okay, how did I define a passive patient? Yes, how did I define a passive patient? Yes, Peter, go ahead.
A patient who needs assistance to turn left, turn right, get up in bed.
Okay.
Just vice versa of there.
Okay, so a patient who need your assistance before the. So that means that from today, with this definition, you're not going to go anywhere and go and say that obese patient is passive. Please. Sometimes I don't know how you people come about all these things. Don't go anywhere and go and say obese patient is active. Now, from this definition, what it means is that even if you meet a dead patient who can turn left, who can turn right, who can sit up in bed, that patient is still active. From this definition. which we know it wouldn't happen.
So
But
please, I want to ask
this
a
is what
question.
this is what I want you to keep in your mind. This is what I want you to keep in your mind. So don't go anywhere and go and say, even if you go and meet unconscious patients, who can turn right, who can turn left, who can sit up, that unconscious patient is active. This is how deep I want you to understand it. You will not go and use, so don't go and define passive and active using conditional. You can have a stroke patient who is very active. So the other time I asked some student, when do we say patient is passive? Say stroke patient. Who told you? Haven't you seen a stroke patient walking before? Yes. So we don't define passiveness and activeness using condition, using obesity. Do you get it? And you can't say you define activeness and using fracture patients. No. You can have a fracture patient who is even more active than a patient with malaria. So please, this is how we define activeness and passiveness. We don't use condition. We don't use the patient's body. We don't use, no, this is the definition. Okay, yes, any other person? Yes, you wanted to ask a question, young lady. Go ahead.
What about the children?
Uh-huh.
Like when you are at the kids' ward,
Okay.
you know, mostly the others have been helping them, or once the child can sit on his or her own, it means the child is active.
Madam, that is the definition of the same thing. That is the definition. You remember the definition? If the patient or the person in question can sit up in bed without your assistance, can turn left without your assistance, can turn right without your assistance, can even make attempt to get out of bed without your assistance, that child. Hey, so yeah, have you forgotten the ABGA score? Yeah, we are all learning obstetrics. So you can, how did they measure? Go and check ABGA score. Even toddlers, they measure their activity level. Yes, they measure, they have parameters. The midwife, their own cry is even more scary than what I'm saying. They can even use facial expressions and other things to even measure the activeness of children. So for children, cry is even much easier. Okay, so if the child can, it's the same definition. If the child can get out of bed, the child can turn in bed without the mother's assistance. Not necessarily the dimension of the mother having to always, you can have an active child who the mother will still have to. Even some of us, when we were even 5 years, 10 years, our mothers were still bathing us. You get it? So that is still the definition still remains. Okay, so you can have a child who is active, whose mother may still have to assist with personal hygiene. Have you gotten it now? Have you gotten it? Hello, young lady?
Yes, sir.
Okay, that is fine. That's fine. So
Yes, sir.
now we all know the routine care. So let's carry on. We have the routine care at the front page of the care plan, the lower part. That is where. So right after your candidate's name and candidate signature, come straight. Please, sir, follow the system. You don't commit errors. Okay? No known allergies. Then you come to the routine care. You write the routine care. Quickly turn to the back page of the care plan. In fact, even if you turn, before you even turn to the back page of the care plan, this is what I want you to do first. Okay, open to the inside of the care plan. When you open to the inside of the care plan, do this. If you are going to do 3 care plan, I would always advise you that do 4 care plan. If you are going to do 4 care plan, divide the care plan like this into 4. Have you seen what I've done? Learn how to divide it into 4 equal parts. Practice it. Learn how to divide it into 4 equal. The parts should be, practice how to do it. That you divide the care plan. So it means you always have to go with a long rule and practice how you divide the care plan into 4 equal parts. Now look at this. Someone can fail in care plan because of this. The first half of the care plan, the first start, how many minutes are you supposed to do? 30 minutes. Are you aware? Are you aware you are supposed to do 30 minutes, the first half? Please, are you all aware the first half? The first part, when they give you the care plan, they sign you in, you are supposed to do 30 minutes. I hope you are all aware. Hello, can you hear me?
Yes, please.
Good. So the first part, you are supposed to do 30 minutes. Now look at this. You write, let's say they gave you the care plan around 8. You write 8 a.m. Now, the next problem or the next diagnosis, you wrote, let's say, 8:50. Okay, then your next problem, you wrote 10 something. It means that your care plan, you did or you are allowed to work more than 30 minutes. Straight away, it's a failure. Most of you, your mind have not come there. And people, their results come and surprisingly, they are having issues. They don't know where the problem is coming from. These are some of the petty mistakes. Is that okay? So the advice I'll give you is that quickly, before you even turn to the page, turn to the back page, quickly do this thing first. Divide your care plan into 4. You are not coming to do the care plan proper. Remember, everything you are doing is saving the time. Every step you are taking is saving the time. If you write it, there is no problem writing the date and going back to go and do the medical orders and come back again. Whatever you are writing is a time-saving strategy you are doing. Okay, so quickly, the date that you are doing the care plan, write the date. So once you divide your care plan into 4, so 1, 2, 3, 4. That is if you are doing 4 care plan. If you are doing 3, this is how you divide it. 1, 2, 3. That one you divide into 3 equal parts. I'll always advise you divide it into 4. Once you finish dividing into 4, at the date side, write the date you are doing the exams and the time for all the spaces. Write it there. The reason is because anytime 10 students or candidates submit their care plan, 3 of them, they don't write date and time. An examiner can decide to penalize you because of that. And most of you have done it before, as we are talking. As we are having this discussion, most of you remember you've done this before. And surprisingly, some people will still commit. The whole of this week, I've been marking care plans. I've been examining students. Students are still committing that error. Meanwhile, there is a simple way to overcome it. And that is the way I'm teaching you. Okay, so you divide it into 4, write the date you are doing the exams and the time that the vigilator issued you in. Maybe they issued you in around 10 a.m. So the first box, you write the date, maybe 20th July, 20th 07, 2025 at, you can choose not to bring this at, or you can use the normal 80. So 20th 07, 2025 at, then you write 10 a.m. The next space, write 20th, then write 10:05. You can even do 10:02. Don't use more than 5 minutes interval. If you use 10 minutes interval you end up at 40 minutes. That means you did about 40 minutes, which is also a cheat in the exams. So please be very careful. Most of your mind have not come there, because see, if let's say 10, 8 o'clock, 8:05, that is 5 minutes. 8:10, that is 15 minutes. And then 8:15, that is 20 minutes. Meaning this person used 20 minutes for the inside of the care plan. And that is realistic. So the remaining 10 minutes, the person used it for the other places. That is realistic. Someone too will do 2 minutes. Let's say 8:02. 8 o'clock, 8:02. Okay. The next one is what? 8:06. And then the other one is what? 8 what? 8:08. Meaning the person used 8 minutes to do the inside of the care plan, which is also realistic. It's within the 30 minutes. But if you do 8 o'clock, 8:30, 9, 10, at the end of the day, you put all together, it will be more than the 30 minutes. Meaning there was cheating somewhere in the exams. Please, are we good? Please, are we good with that? Are we good? Hello?
Yes, please.
Good. So always remember, once you open the inside of the care plan, just do this division and write the date. When you do the division and write the date, you are not coming to do the care plan proper. You are writing this there to take yourself out of the percentage of students who commit that error. In fact, I don't have a problem if you finish writing the allergies and you decide to even open and come and divide. Do you get it? And decide to even open and come and divide. So all these things I'm saying, let it click in your mind, so that you take yourself out of that percentage of, and the students who commit this error, do you know, surprisingly, they are usually the brilliant people. The students who commit this error, they are the brilliant people who have really learned the thing. They know. They will submit no dates, no time. Usually the brilliant people. Is that okay? So be very careful. So you write the date, and don't assume that you write one date and time for the first problem and it goes for all. You write one date and time for the first problem and you are assuming that it goes for all of them. No, it doesn't go for all. Is that okay? Good. So, have you all gotten it? Can someone summarize what I'm saying about the table? Someone should summarize what I'm saying about this table. What I just said about the table. Yes, one of you should summarize.
Please, you said with the division, it's supposed to be either 3 equal halves or 4 equal halves.
Okay.
And with the date and time, it's supposed to be within 30 minutes, not above 30 minutes.
Okay. No, I don't agree. That is not what I said. The main juice in what I said, you didn't mention it. So I won't agree. The main juice, the exact points that I want you to say concerning that, I just didn't say it's supposed to be within 30 minutes. I give a specific description on how to achieve that. It's not supposed to be within 30 minutes. It's supposed to be less, because even if you do it within 30 minutes, I can question you that, okay, if you use the entire 30 minutes, if I calculate and your entire 30 minutes here, it's what you use to do the inside of the care plan. How did you write the other spaces? The medical records and then the personal data and the routine care. Which minutes did you use to do that? That is not what I said. Yes, any person to explain? Yes, any person to explain?
Sir,
Yes, please, go ahead, I'm listening.
sir, with the date and time, it's like if 14th, like those of us doing it coming Monday.
Okay.
So 14th will run through, but
Okay,
with the
so
date, so with the date, assuming we entered 10 o'clock a.m.,
okay,
then it means with the first one we can use 10:05 a.m. Then the
10:05
second,
a.m.
yeah, then the second 10:10.
Excellent.
Then the third 10:15.
10:15.
Then the fourth, yeah, then
10:20.
then the third, yeah, 10:20. So it means you are still within the parameter.
Good. So at the end of the day, it means the inside, roughly you use about 20 minutes. You
Yes,
get it?
sir.
You use about 20. If we put the timing intervals in your inside of care plan together and you get 30 minutes, it means there's cheating somewhere. Do you agree? Because what minutes did you use to do the other areas? Do you get? So if you put the inside time together, okay, from the first time that you wrote the first problem to the last, you put it together in 30 minutes. It means there was cheating somewhere during the exams, and your paper should be questioned. Because how many minutes did you use to do the personal data, the medical records, and those things? So please be very careful. I'm giving you instructions on the simple errors people commit that goes against them. Be very careful. If you go and write 8 a.m., 8:30 straight, it's fail. It's fail. It will come surprisingly, you'll be shocked. Simple errors. Is that okay? So pay attention. I'll even advise you use 2 minutes interval. So 8 o'clock, 8:02, 8:04, 8:06, 8:08. Just use 2 minutes interval. But maximum is 5 minutes. Maximum 5 minutes. Don't forget. Maximum is 5 minutes interval. Maximum. And write this thing before you even come to this table. Write this thing before down. The reason why you are writing it down is to save yourself from that percentage of students who complete the care plan without writing date and time. And mostly exams, anxiety, and pressure. If you do the inside first before the date, you are more likely to forget. Exams, pressure, and then anxiety. If mostly people who write before they decide to write the date, most of them forget. Okay, so please remember that. Okay, so if you are dividing it into, so look at this. If you are dividing it into 10, okay, so you are dividing it into 3 equal parts. That means you are going to do 3 care plan. Ideally, you are supposed to do 3, but I always advise you to do 4, because if you do 4, the examiners will mark all the 4. Okay, they will mark all the 4 and choose your best 3. But if you do 3 and 1 happens to be wrong, you are being marked over 8. Imagine you've done 3 2 is wrong, you are being marked over 4. That's why I always advise students, do 4 all the time. Okay, so that if you have issues with even 1, the other 3 will be outstanding for you. Okay, so if you are dividing this into 3, you've written your dates for all. The first time, let's say you were issued in at 10 a.m. So 10 a.m., 10:05, 10:10. You see, 5 minutes interval. If you put these together, is it not 15 minutes? 15 minutes, which is realistic. Is that okay? Which is realistic. Okay, good. The nursing orders and intervention, you're expected to state 3 orders. But please, all the time, try to state at least 4. Okay, so 3 orders will give you 1. Then you write their corresponding interventions. That will also give you 1. Is that okay? So the orders, make sure you write the orders properly. Is that okay? Good. There is nothing like date and time and evaluation. In the nursing care plan licensing exams, we only have evaluation. Okay, I'll show you how we write the evaluation when we move on in the nursing care plan. Okay, now let's look at, so after when you open inside, in the first start from the routine care, look at the system, look at the format. From the routine care, after you've written no known allergies, you've written all the routine care, come straight to the inside here. Okay, you write the date time for all the 4 boxes like this. You write the date time for all the 4 boxes. That is the only thing you are doing, the division and writing the date and time. Flip, and remember, everything you are doing is saving your time. Then quickly you come to this side, the medical records. Okay, so now Peter, come in and ask your question, please. I'm listening.
Sir, please, with the timing that you just taught us, I wanted to confirm once again from you that, assuming, as we said earlier, like you entered, then you write, let's say the first one 10:10,
okay,
or 10:15, then the next one 10:20, then those ones. Then means, as we said, it's like you feel the work. But this morning, frankly speaking, it's like I'm sad. I've gone through a series of lectures on this thing, and nobody has even commented on this timing aspect you are saying.
Yes, that is the reason why you have to join classes like this, so that you learn. Everything comes with experience. You can even be a student and have more experience than your lecturer. I will not be surprised, as an academia like me, I will not be surprised if, Peter, one day you have experience even in these things to teach me things I don't know. That is how learning is. Yes, and that is how you always have to be, to be eager to learn things as a student. You get it? Yeah, so don't be surprised. And those people too, it's not their fault. All this thing comes with getting exposed to information. You get it? So you see now, your mind have been open to how people can commit simple errors. So it will come in massive number of errors. They will understand. These are some of the simple errors that they can use to. And if you are going to argue, they can bring it to come and prove you that indeed you failed. You get it? They have the document there to come and prove that indeed, okay, you people are challenging. You've paid for the okay, let's go into paper. Look at what you did. How many minutes are you supposed to do? Oh, please, you are supposed to do 30. It means the regulators allowed you more time. You agree? Look at the document. Then you see you'll be quiet. That is it. Simple errors. Okay, simple errors. So you always have to be very smart. Be very, very, very smart. Is that okay? Be very, very, very smart. Okay, good. Any other question? So now let's start with the medical orders. So now, after you've done the inside, after you've done this inside, quickly turn the page. The inside, when you do this, then you are just ruling these pages, ruling the lines, dividing it into 4, writing the date and time. That is the only thing you are doing. Then quickly, you come to the back of the care plan here, the medical records. Now, please, the advice that I'll give you is that the medical records, the medical orders, that's the back page of the nursing care plan, is 2 marks. The first thing I want you to write this thing: no other treatment requested. Please. These exams you are going to write in, there are things that makes the exams easy. Students sometimes want to make it difficult for themselves. If you write 20, no other treatment requested. Let someone write 20 other treatments. Let someone just write no other treatments requested. The person will get half, you get half. If you like, use the entire 30 minutes to write about 20 other treatments. Let me just write no other treatments requested. You get half, I'll get half. Why are you rushing to go and even waste time? And most of the time, students who even end up searching for other treatments, you end up using about 5 minutes. In future, when you come to work on the ward, you'll be searching for this, the no other treatments. But for now, for the exam, because of time, write no other treatments requested. Now, but the caution I will give is that there are times that it's so obvious on the ward that a particular patient they've assigned you, probably that patient is on physiotherapy or that patient is on chemotherapy. Please don't use your knowledge on literature to go to the ward. That a patient with, they've given you a patient with cancer, so all cancer patients are on. No, it's not all cancer patients who are on chemotherapy. It's not all cancer patients who are on radiotherapy. It's not all of them. It will even depend on the stage. Okay, so you don't use your knowledge. It's not all stroke patients who are on physiotherapy. It's not all patients with fracture who are on physiotherapy. So you don't use your knowledge from literature to go to the word that they gave me a patient with fracture, so the other treatments I wrote physiotherapy. No. Usually it should be prescribed by the physician. And some of you have not even seen a physiotherapy request form before. If not seen, some of you, if you tell you search through patient papers, identify physiotherapy request form, you can't. You get, it should be prescribed. Okay, so please, all the time, please write no other treatment. In fact, for these exams you are going to write, you write this and get your half for me. Don't stress yourself to go and search, to waste time. But sometimes it's obvious. You are going through the patient chart. You've seen a dietitian plan on as part of the patient papers. Fine. It tells you patient is on diet therapy. Is that okay? It tells you sometimes the indicators are very clear. Sometimes you've even see indicators that patient is doing physiotherapy. Sometimes it's very clear. In fact, we even have some wards that every patient, for example, if you come to Kolebu Stroke Unit, it's compulsory. Every patient on that ward is on physiotherapy. So in such an environment, that one you know. Okay, and usually if you know that patient is on other treatments, the date or that use the same date of admission. The same date of admission that you've identified, write the same thing there. And you know another logic, and do you know another reason why I want you to write the medical orders before you come and write the personal data? You know the reason why. By the time you finish writing the medical orders and investigations, you already know the patient diagnosis before you are coming to that site. By the time you finish writing the patient's medication and then the investigation, you've already seen the patient diagnosis. That is the trick. If you like, check. By the time you finish going through patient's medications and even going through the investigations, you already know the patient diagnosis already. You know it. And most of the time, if the patient has even done an operation, you get to know from doing all these things. Is that okay? Good. So quickly, you write no other treatments requested, just like this, and see how I've written it. Don't go and write it diagonal. You see, some of you write it diagonal. Have you been writing it that way? You write it diagonal from this side to the top. Write it like this, no other treatment requested. And see, you see, it is covering the 3 columns for the other treatment. See, it is covering the date ordered, the order, and then the date completed. It is covering that space. Don't write it in a way it extends into the investigation. Don't write it in a way it extends into the medication. No other treatment requested. No other treatment requested. Okay. Now, in a situation where you find other treatments, it will be something like this. Okay. These are some other treatments. You see, physiotherapy, chemotherapy, diet therapy, occupational therapy, speech therapy, dialysis. Please listen. If you are able to identify any physiotherapy, I said make use of the date of admission. Don't write any, make use of the date of admission. Don't search for any date, please. Do not search for any date. Use the same date of admission. Or you can backdate just 5 days ago or backdate just 3 days ago. Backdate just 5 days ago or backdate just 3 days ago. Okay, then you write the date completed, write not yet. The date completed, write not yet. Don't search for any date completed. Don't ask anybody. Don't move to the next station. Write not yet over there. Are we good? Please, are we good? Are we good? Okay, so we have physiotherapy, we have chemotherapy, we have diet therapy, we have occupational therapy, we have speech therapy, we have dialysis. You realize that there are 2 therapies that you people, I know you know, which I have not mentioned: oxygen therapy and blood transfusion. In fact, these 2 other treatments, I won't advise any of my students to write, because I've seen examiners who think blood transfusion is supposed to be under medication. And I've also seen examiners who think oxygen therapy is also supposed to be under medication. So please, please, and please, and please, the other treatments, don't write oxygen administration. Don't write oxygen therapy, because what if the examiner you are going to submit to is an examiner who believes it's supposed to be under medication? So please write no other treatment. In fact, for these exams, go with the mindset that you are going to write no other treatment requested. When you turn the back page, write that one first. Please. When you turn the back page, write that one first. All right. Now, the next thing that you write at the back page is the medications. This. Now, do you know that the medication and investigation too, you can have a patient who know medication is ordered. Okay? You can have a patient who know medication is ordered. Yes. Valeria, I'm listening. Go ahead and ask your question.
So please, are you saying that after you write the no other treatments, the therapy, we should still write them? We should still write the therapy.
Oh, madam, no. I'm giving you the various options of things you can write there. Even the physiotherapy, I'm not saying we give you any patient, go and write physiotherapy, chemo. No. What I'm saying is that I'm giving you the range of other treatments you can write or you can get. You get it? And I'm telling you that
yes,
if patient is on no other treatment, you can't be writing physiotherapy, chemotherapy, diet therapy. No. If you write no other treatment, that is it. Like this. It will be like this. If you write no other treatment, this is the only thing we will have there. You can't write anything under again. You get it? On this slide, I'm telling you the range of things that can be written at the other treatments. Okay, so you see, I've bolded the no other treatment. So if you wrote no other treatment requested, that is the only thing we should see there. You can't write no other treatment requested and come and write physiotherapy, chemotherapy, diet therapy. No. But I'm saying I've given you the range. These are some possible other treatments you can have for a patient. Okay. You can't have one patient, physiotherapy, chemotherapy, diet therapy, occupational. Hey, then this patient is dead, though. Oh, physiotherapy, no. Here, I'm listing some range of other treatments that we can have. And I was saying that if in case, let's say, your patient is on physiotherapy, when you write physiotherapy, use the same date of admission or like backdate like 3 days or backdate like 5 days. You can even backdate the previous day of the exam. So you are doing your exams, is it 20th? So you can backdate 19th and write. Backdate. Don't make any attempt to search for any dates. Then the date completed, write not yet. The date completed, write not yet. Not yet. Not yet. Are we good? Are we together? Please, are we together? Okay, now the medications.
Sir, please, I have a question.
Yes, Juliana,
please,
and I ask your question.
Okay, so with the oxygen and then the blood transfusion.
Yes.
Please, where can we group them?
That is why I have not put it anywhere. I don't even teach it. So in this lecture, I assume that Mr. Sylvester have never mentioned it anywhere. If you learn it anywhere, fine. That is fine. But I have not mentioned it because of the experience that I have. Do you get it? Yes, so the advice I'm giving you from experience is that some examiners think it's supposed to be under other treatments. Others think it's supposed to be under medication. So I don't even teach it. I will tell you, if you see it, don't even write it anywhere. Just go with no other treatments requested. Are we good? Okay. But if your confidence tell you from another side that, okay, I'm giving a patient on oxygen, I think I'm writing it under other treatment, fine, write it. but I didn't teach you that.
Okay.
So that
Yes,
you go
please.
with the fit from that angle, from that side.
Okay.
Is that okay? Good. Because
Yes,
some
please.
examiners think oxygen therapy is supposed to be a medication. Yes. And others also think so blood transfusion is also supposed to be a medication. Is that okay?
Okay.
Good.
Yes,
Yes.
please.
Yes. But you may learn it other places that it comes under other treatments. You get it? Yes. So basically that is it. That's why I have a range of other treatments, but I didn't add blood transfusion, and then I didn't add oxygen therapy. Do you get it? Yes. And if you come to my medication slides, you see I didn't even add blood transfusion. I didn't add those things because I don't want to commit from the experience. Just omit it. Right? No other treatments. In fact, what I am considering paramount over here is please go with the mindset that you are going to write no other treatment in the middle here. Write no other treatment. Go with this mindset. Why do you have to go and struggle to waste time than where you can just write no other treatment and still get your half? Is it difficult? It's not difficult. And in exam, some of you students, you are hard on your own self. You are hard on your own self to the point that someone will be struggling now and even end up leaving the space empty. How else you can write no other treatments? Is that you can also have a patient that is not on any medication. In such a situation, that one usually wouldn't occur. In such a situation, you write no medication ordered. You can have a patient who is not on any medication. Please, that one too don't occur mostly. In such a situation, you write no investigation requested. Now, what usually occur? You find medications, you find treatments. This is what you do. Now, look, in most of the hospitals now, especially those going to like 37, Rich Hospital, Kolebu Teaching Hospital, the medications, you are supposed to write a complete dosage. Okay, or a complete prescription. When we say complete prescription, you should mention the route of the medication. You should mention the dose, the frequency, and the duration. So here, you see the tablet is telling us that it is oral. 1 gram is giving us the dose. 8 hourly is telling us the frequency. And then 7 days is giving us what? Is giving us the duration. Now, most hospitals, the doctors, they usually write open dosage. So you see tablet paracetamol, 1 gram, 8 hourly. You won't see the number of days. If you are writing it under the medication, please add this statement to it until reviewed. So you see here, intramuscular pethidine, 100 milligram, 8 hourly until reviewed. Especially those going to Kolebu Teaching Hospital. The dosage is usually open dosage. Have any of you seen that written before? Yes, have any of you seen that written before? They write the prescription. They don't add the number of days. They don't add like 24 hours, 48 hours, 72 hours, 7 days, 5 days. Have any of you seen it before? Yes, have any of you seen it before? Any of you seen that written before? Oh, none of you have seen that before. All right, that is what we call the open dose or open prescription. Okay, so they don't state the number of days. Okay, in such a situation, don't write and leave it like that because we expect you to write a complete medication. So that one you add until reviewed, this word, until reviewed. So if you are looking at your medication, the number of days or the hours is not there, and you didn't add this statement, it's not a complete prescription. And please don't write tap P more, tap paracetamol. No, tablet paracetamol, 1 gram, 8 hourly times 7 days. Then you write not yet. Now, if for the first start of the care plan, the 30 minutes, if your patient is on about 10 medication, please write 4. Maximum write 4. You can even write 3. Let me repeat that again. The first start of the care plan, if your patient is on about 10 medications, write about 4. You can even write 3. Don't write all the 10. By the time you finish writing all the 10, more than 5 minutes is gone. More than 5 minutes is gone. Write 4 or maximum. Maximum is 4, or you can write 3. Okay. Now, if look at these medications, you see first medication, second medication, third medication, fourth medication, you can see clearly that all of them were prescribed on the same date from the treatment sheets. But you realize that I've written the date separately for all of them. I didn't write the date once and want to assume or employ the examiner that the date goes for all of them. So if you are writing 4 medications, even if it's the same date, write the date separately for all of them. So you see, even though it's the same 10th, I've written the 10th 07/2025 for the tablet PMO. I've written the 10/07/2025 for the intravenous ceftriaxone. I've written it again for the subcutaneous cleansing. I've written it again for the intramuscular. You get it? And here the date completed. Right? Not yet. Right? Not yet. Right? Not yet. If patient is on medications like 5 medications that he has stopped taking, then patient is now on 5 new medications he's currently taking. Don't write any of the medications that he has finished taking and come and write a date completed. Just write about 4 of the medications he's currently taking. Or if patient is on, let's say, 3 medications, patient has completed 1, patient is still on 2. That one you can write all the 3. Then the one patient has completed, you can write the date completed. Don't make any attempt to search for if they write stop. Just trace the stop up where the dates that the stop correspond. Use that date. Usually that is on the treatment sheet. It's very easy to identify. Is that okay? Good. So if patient is on 5 medications, all of them were prescribed the same date, fine. There are times that the doctors or the physician wouldn't write the date the medication was ordered on the treatment sheet. In such a situation, use the date of admission that you wrote. The date of admission that you wrote under the personal data, these dates of admission. The date of admission of the patient, use the same date of admission. Is that okay? Don't go and think. The same thing applies to the investigation. Use the same date of admission. Don't go to nurse's station to go and search for date medication was ordered. Okay, don't waste about more than 1 minute searching for date medication was ordered. Use the same date of admission. So that means that if you have 4 medications and on the treatment sheet, the date the medicine was ordered is not written on the treatment sheet, please write the date of admission 4 times against all the medication. Don't write it once. And as if some people to write the date like this, then they will write 2 bar under. They will come and write another 2 bar under, another 2 bar under, meaning the same thing, the same thing. No, this is a formal exam. So you can't write. Can you go and write WASI and you write a date, then you write 2 bar under to tell the examiner that the 2 bar goes for all? No. You write the date separately for all of them. And you see here, I'm writing tablet paracetamol in full. Don't write TAP, TB. Don't write IV. Don't write SC. No, write in full. Suppository diclofenac. And you see here, because the duration is not there, I've added until reviewed. Is that okay? Any question on the medications before we move to the last, which is the investigation? Any question? Hello? Hello?
Yeah, hello, sir.
Yes, I'm listening.
Please, with the medications, can you add the fluids, IV fluids to the medication?
Yes, intravenous normal saline. So you can add intravenous normal saline, 500 ml. Let's say daily for 3 days or daily for 24 hours. Yes. So you see over here, I've added 24 hours, meaning the duration is there. 24 hours is 1 day. Okay. But if if it is open, then you write intravenous normal saline, 500 ml daily until reviewed. Is that okay? Great. So you can add infusions to it. All infusions comes under medications. Are we good?
Sir, thank you.
Welcome. All right. So now let's go to the investigations. All right. Now, investigations. Investigations, if well written, will fetch you half a mark. Is that okay? Now, under the investigations, most patients in most hospitals has this lab, the full blood count. Now, if you are writing full blood count, you write full blood count in capital, then you underline. Then, you know, full blood count has a lot of components. So it has about 20 components under it. You don't need all. You need about 3 or 4 of them. So you need red blood cell, white blood cell, hemoglobin, platelets. So red blood cell, white blood cell, hemoglobin, and then platelets. Is that okay? Then you write their corresponding results. So you write full blood counts nicely like this, then you underline. Then you write red blood cell, white blood cell, hemoglobin, and then you come and write their corresponding. Don't bring the components under the result side. Some people write full blood count over here. Then when they come to the result side, they come and write the red blood cell under this side, and then write the results against it in this box. It should be under it in the middle. Okay, then you can rule a line to join to come and write the corresponding results at the result side. We only write results at the result side. You can't come and write the name of the component or the lab at the result side. Please remember that. Then you have to write the date. Okay, you have to write the date. Some of you are not having the original care plan. The care plan you are using to learn is the one that has date completed over here. So I saw some people who brought their care plan for me to mark, and I saw over here date completed. No, the original care plan here is results. If you have that format of care plan, you will learn how to come up with the results and then how to write the results. Now, another lab that you can meet for most patients in hospitals is the blood urea electrolyte and creatinine. Blood urea electrolyte and creatinine, BUE and creatinine. That one too is a composite result. So you look for the components under it. You usually look for creatinine, potassium, sodium, chlorine, and urea. Then you write their corresponding results. This lab too have a lot of components under it, just this 4. You can even write any 3 of these ones. Now, if someone is able to do something like this, even just the first one, the person gets the half. Okay. If you are able to also do just this one, you get half. If someone is able to write about 10 different labs, the person too get half. So the ball is in your court. Okay. We have other labs like this. Okay. You can have a patient electrocardiography. This is the results. Biventricular hypertrophy, X-ray of the left leg, left femur fracture, abdominal ultrasound, multiple uterine fibroids.
Hello, sir.
Yes, please.
Sir, please, with the labs, where will you get it from? Is it from the system?
Oh, the patient's documents. Usually, every patient has a file at the bedside in most hospitals. So the patient documents. But in an exam, there are some facilities that they keep it in a folder or a cupboard. During exams, they will bring it out for you before you start the exams. So you have to request. But for hospitals that I know, like Kolebu, Reg, and 37 and others, you meet those things at the patient bedside, the nursing papers, and then the patient file. Patients always have a file at the bedside. They will be inside. Is that okay?
Yes,
good. So these are some results. And apart from that, there are some investigations that you use your knowledge from literature review to get, not necessarily searching. For example, so that means your med search should also be good or solid. For example, they've given you a patient with stroke, let's say subarachnoid hemorrhage. Now, in the investigations, I'm not expecting a smart student to go and search for any investigation because, internationally, the standard way of diagnosing stroke is CT scan. Of course, you definitely see a CT scan there. No doctor will diagnose a patient's stroke without using a CT scan. So it is up to you to know that from medicine so that you don't even waste your time searching straight. You write CT scan, you know the results. The results will be the diagnosis of the patient. Let me take your mind to another example. No doctor will diagnose a patient with fracture without X-ray. So if you are doing a care plan for a patient with fracture and I see that you are searching for results, I can tell clearly you are not a good student. You shouldn't search for any results straight. You write X-ray. Do you know the results? The results of the X-ray is the patient diagnosis. So if the patient has been diagnosed left femur fracture, that is the X-ray results. Did you get it? Another example is a patient who is having diagnosed of diabetes. In fact, how did they diagnose the patient with diabetes? Yes, how did they diagnose patients with diabetes? What is the standardized way of diagnosing diabetes? Yes, what is the standardized way of diagnosing diabetes? Have you heard of glycated hemoglobin? HbA1c. Have you heard of it before? Have you heard of HbA1c? Yes, definitely they will do HbA1c. Do you get it? Yes, so there are some for example, a patient is having appendicitis. Of course, there is no way patient will not have abdominal ultrasound. You shouldn't go and search. Once you are making an attempt to search, it shows your surgery is not strong. There is going to be an abdominal ultrasound. How did they diagnose? And what is the results? The results is inflamed appendix. Do you get it? So you are doing a care plan for a patient with multiple uterine fibroid. Is that okay? Now, there is no way they will diagnose that without abdominal ultrasound, lower abdominal ultrasound, okay, or abdominal pelvic ultrasound. There is no way. So it's up to you to be very sharp or smart with your surgery to know that definitely the standard diagnosis is abdominal ultrasound. What will be the results? Multiple uterine fibroid. Are you getting it? So some of them, anemia, for example, there is no way a patient with anemia is not having full blood count. Do you get it? So full blood count, then it means you have to concentrate on the red blood cells, hematocrit, white blood cells, and then hemoglobin. Because there is no way they would diagnose a patient with anemia without full blood count. So if you are doing a care plan for a patient severe anemia, you are going to search for the full blood count first before you come and write. You have a problem. You have to write it and search because there is no way the doctor diagnosed me. How did the doctor diagnose patient severe anemia without full blood count? It's not possible. Is that okay? So some of them, you use knowledge from literature review. Knowledge from literature. A patient with tuberculosis, what test are you going to search? Why are you going to search? If you are searching, it tells me your medicine is not good. Straight away, you should write. Once the diagnosis has been written, listen, once the diagnosis has been written, patient is having tuberculosis. A smart medicine student, you don't search. If you search, it means your medicine is weak. Straight away, you write. Sputum culture, the answer will be, results will be positive. Montos test, results will be positive. Chest X-ray, you are going to see inflamed lungs or patches in the lungs. You don't search. No, please, are you getting the revelation? You don't search. Some of the things, you use your knowledge from literature. Do you get it? Please, are you getting it? That one is a deeper level. It's a different side altogether. I know with time, some of you will begin to also use that one too. So there are some things that you know from literature. You get it? You know it from literature. Okay, that is fine. That is fine. So now we are done with the medical records. Any questions on the back page of the care plan? Any question on the back page of the care plan? So that now we can now go to the inside proper. Okay, so I started by saying that the first thing you write is your candidate index number, then you sign. Don't write anything under the personal data. Don't write anything there. Quickly go to the known allergies. The allergies and write known allergies. Then you come to the routine care. Now, do you know what? Do you know why I'm taking you through all this? The reason is because these things, they are copy work, especially the routine care. The routine care is not even a copy work. It's something you know before you are going to the exams hall. It's like you are going to write those days when you are writing exams in secondary school. They ask you, okay, answer. They give you 4 questions. They say answer any 3 or answer any 2. Which one do you start first? The one that you know best will be the one you start with. I don't think any of you go and start from the ones you don't know. And this is how this exams is. And this is what some of you have not realized why you are not able to finish care plan. We've given you an exam. We said some area is copy work, some area you already know some things. The students say, I want to finish with the area I will think first. Simple logic. Most of the students are saying, we want to finish with the area we will think first to waste time. Then at the end of the day, they will not be able to finish. Okay, there are some areas you are just going to copy. Those are the ones you attempt first to. The ones you are going to think, if you attempt them first, definitely you won't finish the care plan. Okay, so routine care, straight, sharp. You write the routine care, you are done. You don't leave any space unwritten. After I've taught you this, if you still do care plan, leave a space unwritten at the routine care, there is a problem. You have a problem. After I've taken you through this routine care, this is what you write. Memorize it and go and write. Don't go and leave any space blank. Then you come to the medical records. It's copy work. The patient is already having treatment sheets. In fact, if you are smart enough, these medical records, you don't even need any charts from the patient. Once the patient's medication container is there, now the pharmacy, if the patient bought the medicine from the pharmacy, if like enter any hospital and go and check, if patient bought the medicine from a pharmaceutical shop, the medical order is written on the box of the medication. You've all bought medicine from pharmacy before. In fact, the pharmacist even writes it better than the doctor, if like check. Yes, if you go to, sometimes I'm surprised you rather concentrate on the treatment sheet. Fine. There can be a time patient to have some medications in the treatment, in the container, which is not on the treatment sheet. That is accepted. I agree. But I want you to understand that the pharmacy will even write the dosage better. The pharmacy will even write, okay, 2 taps, 1 tablet, 3 times daily, times 5 days. The pharmacy will even add the duration. That is what your mind have not even come on. So I always say that this back page, you don't even need the patient chart if you are so smart. You don't need the patient chart because the other treatment is straight. No other treatment. The medications, the labs are already there. The medications, if the patient chart is not even there or the treatment chart is not there, the patient's medication container is there. And mostly, if it is Doretta, the pharmacy have written how it's supposed to be taken on it and even written it better than the doctor. If like some pharmaceutical shop, they even go to the extent of writing even the date on the box. If you like check. Okay, just that most of you have not even paid attention to that. You get. So this is it for the medical orders. Okay. Any question on the back page of the care plan quickly before we move on to the personal data, so that I teach you some key things under the personal data. Yes, any question? Any question? All right, no question. So now, so you see, from the index number, you come to the allergies, you come to the routine care, you open the inside of the care plan and do the ruling, and then you write the dates down. You turn to the back of the care plan and quickly do the medical orders, the medication, you do the other treatment, you do the investigation. Then you come back to the front page again, and now you come and write the name of the patient. If remember that before you started, they assigned you that this is the patient that you are using. You've already established rapport. You don't talk plenty. Most of the time, listen, students that are talking plenty during care plan, they are students who don't know anything. They don't know what they're about. The students who are talking plenty, if you like check, in future when you become an examiner, observe, students who are talking plenty most of the time, within the 30 minutes, they don't know what they are about. In fact, they are not thinking straight. They've gotten memory loss. Those who know what they are about, you don't talk plenty. You do your simple rapport establishment, your simple observation, you start writing, you are done. Do you get it? So you already know the name of the patient. Now, there are some things that you already know at this side. In fact, by the time you finish the medications, the investigations, and other treatments, I'm telling you, you already know the diagnosis of the patient. You already know the diagnosis of the patient. Okay. Now, the ward. By now, I think you already know your wards. By now, your school have already sent a distribution of all your wards, and you already know. Okay, so I will be very surprised when on the day of the exams, someone is asking, sister, please, what is the word? I'll be very surprised. Because you already know the word, though, before you go. And I'm sure, Peter, by now, your school have done a distribution. You already know your words before you go.
Yes.
Yes, so if you go and ask, sister, please, what is this word? You have a problem. Is that okay? Yes. The physician or surgeon, if you are 10 people on the same ward, all of you will have the same name. The physician or surgeon is not the doctor that admitted the patient to. The doctor in charge of the ward you are doing the care plan. What is the name of the doctor in charge of the ward you are doing the care plan? What is the name of that doctor? That is what you write at the physician or surgeon. So if you people attend, one person, the day you report in the morning, one person can ask that for you. So you already know it all. You already know it. The sex, you already know. The age, if the patient can communicate, you already know. The inpatient's number, usually most hospitals now, they have patient's hospital card. Usually they write it on the patient hospital card. And another thing is, you know that the inpatient's number, you can find it on the lab investigations. Yes, if you go to the hospital, check the lab investigation, the inpatient's number is there. The age of the patient is there. The sex is there. The name of the patient is there. So there are some information here. That's why I'm telling you, I'm taking you through a format that I have practiced myself severally to prove that you can finish the care plan even within 15 minutes if you go through that format. So by the time you finish writing the investigation, you already know the patient's name. You already know the age of the patient. You already know the patient's inpatient number, because mostly the inpatient number is on the lab. That is, if the lab was done at the hospital, mostly the inpatient number will be on the lab. Is that especially those going to 37 Reg Kolebu Teaching Hospital. If the patient really did the lab in the hospital, the inpatient number will be on the lab. Okay, the sex of the patient, you know, the occupation of the patient, you can ask the patients, you can find it on the front index sheet. We have a sheet we call front index sheet. On that sheet, the age of the patient is there, the occupation of the patient is there, the sex of the patient is there, the date of admission is there, the ward of the patient is there, the provisional diagnosis of the patient is there. We call it front index sheet. I don't know, now in some hospitals it's getting out of the system, but what they do is that now some of the hospitals, they will cut a sheet of paper into two, A4 sheet into two, then they write those details on it and clip it in addition to the patient papers. Okay, but the occupation, sometimes you can use logic. They give you a patient 5 years old. What occupation are you going to search for? They've given you a patient 5 years old. Why are you being hard on yourself as a candidate? 5 years old. What occupation are you thinking about? Just write students. Just write students. Or you can write unemployed. They give you a patient 80 years old. Why are you stressing to search for an occupation? Write retired. Under normal economic circumstances, such a person should be retired. Don't go and worry yourself to write any businessman. Write retired. Write retired. They give you, don't go and write child or occupation. Don't go and write child. If you look at occupation as a qualitative data, if you are looking at the responses to occupation, if you are doing a questionnaire, you are looking at responses to occupation, do you have child inside? Is unemployed, then self-employed, businessman, trader, maybe civil servant. We don't have child inside. So child is not an occupation. Is that okay? So you can do students, you can do unemployed. You get it? You can do retired, you can do trader, businessman, maybe nurse, teacher. Is that okay? Farmer. Is that okay? Journalist, doctor. Do you get it? Occupation. Okay, so you ask. Sometimes the patient can communicate. You ask. The religion, either Christian, Islam, or Muslim. Okay, you already know your words. I've spoken about that. The bed number. There are some hospitals, they number the patient beds. If they've not numbered the patient bed, you decide how to number. We don't ask. Please listen. The bed number. If the hospital or the ward have numbered the beds, fine. If they've not numbered, you decide how to number. In fact, even if you give me a patient who is in the sluice, and I'll give the patient bed 1. Exams can be easy to pass. I always say this thing. I have written a lot of exams. After completing my 2 masters, I've done a lot of exams. So exams can be easy to pass. Most students book long, choose to make it difficult for themselves sometimes. They've not numbered the best. Why are you going to count 20 before you get to where you are doing? Whilst you can start the 1 from where you are. You are in charge of the numbering now. Why are you going to tend to count 20 and come and reach your point to get 30 to give yourself the 30? Spend about 3 minutes counting. Whilst where you are standing now, you can see bed 1 and start counting from there. The point is that if they've not numbered the best, you decide how to count. So if you want to count other beds about 20 before you get to your time to waste time, it's your own problem. But for me, if they've not numbered the bed, every bed is bed 1. Okay, but just that sometimes we attach some logic. Okay, attach some logic so that maybe bed 5, bed 2, depending on where you are positioned. Is that okay? Good. Now, mostly if they take you to medical wards, the operation side, right? No operation done. Mostly, if they take you to a medical ward, like those going to Rich Kolebu Teaching Hospital or the teaching hospital, okay, regional hospitals, mostly if they take you to they take you to medical ward or the care plan you go and do at the medical ward, always write no operation done. Okay, for example, in Kolebu, for example, if you are on the medical ward, if they will do an operation for you, they will usually transfer you out to surgical ward to go and finish the operation before they transfer you back or they bring you back. Okay, so all the time, if you are going to medical ward, the operation side, write no operation done. Don't write not applicable, please. Don't write not applicable. Don't write nail. In fact, in nursing care plan, there is no space we write nail. Never. We don't have any column over here or any space or anything over here we write nail against it. Never. The date of discharge, you write not yet. The date of discharge, not yet. Not yet. Not yet. All the time. Every patient. By virtue of the fact that patients have not left the ward, all the time, date of discharge is not yet. Even if they tell you patient has been discharged and you are doing the care plan for once in nursing, until patient leaves the ward, patient has not been discharged. You can't have a date of discharge. So the date of discharge, every care plan you do is not yet. Unless maybe you are doing the care plan at the hospital car park, patient has been discharged, have left the ward, and you are doing the care plan at the car, fine. But once patient is in the ward, you are doing the care plan. You shouldn't have a date at the date of discharge. You have, if you write a date there, there is a problem. All the time is supposed to be not yet. Don't write not applicable. Don't write nail. Don't write not time. No, not yet. Not yet. Okay. Now the operation. Okay, the operation. Those going to surgical ward, listen carefully. It's not all patients at the surgical ward who would undergo an operation. It's not all surgical cases that warrant an operation. Or it's not all surgical cases where patients will end up in theater. There are some surgical cases patients will never be to theater. Do you get it? So it's not all cases. And the operation, we are not saying that patient is having appendicitis. Patients have not been to theater, but because you think appendicitis, they do appendectomy. Because of that, you write appendectomy. No. If the surgery has not been done, you don't write the surgery there. Maybe they've given you a patient. Patient tells you, oh, tomorrow I'm going to theater. The surgery has not been done yet. You can't write an operation there. Until the surgery has been done, you can't write an operation. Is that okay? So you only write the operation when the patient has been, in fact, it's not even all patients who go to the theater who they do the surgery. Until the surgery has actually been done, you can't write the operation, and you don't write operation done. You write the type of operation that was done. The type of operation that was done. Is that okay? And now the fact that you saw consent form also, or you see consent form also in patient papers, doesn't mean operation has been done. No. Patient can sign consent form, but will even end up in the theater, but the operation will not be done. It happens. The fact that you saw theater checklist also doesn't mean or confirm operation has been done. No. If you want to use documentation, there are only 2 papers that you can use to confirm that a surgery has been done. The first one is the anesthetic record. It's a big paper. Those of you who have worked in Kolebu would know this paper. It's not like a plain A4 sheet. It's a very big paper and the color is different, like a gray color kind of. It's a very big paper. We call it the anesthetic record, usually used by the recovery nurses and then the doctors and the anesthetic. And we have another one we call the post-op record. That one looks like A4 sheets. These are the 2 papers. If you see it in patient documents, it tells clearly patient has been to the theater. Do you get it? You can't use consent form. You can't use theater checklist. These are the only 2 papers, the post-op record and then the anesthetic record. Once you see this chart, and in fact, if you are blessed and you are doing a surgical case and you see these 2 papers, in fact, you are blessed because there are a lot of informations. You are going to see the operation, you are going to see the diagnosis, you are going to see the age of the patient, the sex of the patient, you are going to even see you are going to see a lot of things on that anesthetic record. Is that okay? Good. So if you go to the hospital, you can ask, especially when you are going to do a surgical, you can ask of these 2 documents, the anesthetic record and then the post-op record. Once you see these two documents, it's a sure confirmation that patient has done an operation. And you even see the type of operation on it. And you see the post-op instructions over there. Are we good? So now we are done with the personal data. Okay, so in the start, so let's quickly go through, see how it goes. Your candidate's index number, your candidate's signature, then you quickly come to the allergies, you write no known allergies, you quickly come to the routine care, you fill all the routine care, you turn to the inside of the care plan, you divide it quickly into 4 or into 3, depending on how you are going to do. You quickly write the date and time, making sure you don't exceed 5 minutes interval quickly. Making sure you don't exceed 5 minutes interval. I would recommend you do 2 minutes interval. If you divide it into 3, you divide it into 3 quickly, you write your time, observe 5 minutes interval, adding up will give you 15 minutes interval. Quickly, you turn to the back page of the care plan. In the middle, you write no other treatments requested. The medication, you look on the treatment sheet, you quickly write. In fact, if it is me and I'm sure I'm writing 3 medications, I'll write the 3 different dates separate first before I'll even write the medication. Here, I'll write not yet 3 times over here. Then I'll write no other treatments requested. The investigation, if I have gotten the full blood count, I write full blood count, I underline, I write hemoglobin, white blood cell, red blood cell, platelets, all in full. I write the results against it. I write the date ordered against it. That is enough for the first start. That is enough for the first start to get your half. If you want to add other investigations to it is allowed, you are not wrong. Then quickly, you come to the personal data. You already know the name of the patient. You already know the ward you are coming. The bed number, if it has not been numbered, you decide how to number the beds. You know the diagnosis. By the time you go through your medications, other treatments and investigations.
Sir.
Yes, please.
Sir, please, with the operation, so if it's not done, would you write not yet?
You don't write. If you write not yet,
will you
are trying to tell us. So, for example, listen. For example, you can have a patient with hernia who during the hospitalization, patient can be discharged without the operation not being done. If you write not yet, you are trying to tell us that whilst patient is on hospitalization, the surgery will be done. So, for example, medical ward, operation side, you write not yet. You are trying to tell us that, okay, whilst patient is on hospitalization, the time will come, surgery would have to be done. Are you getting it? So write no operation done. Don't write not yet. Because if you write not yet, it can be the patient will be discharged, surgery will not be done. Okay. This one is language. This one is about language. So if you use not yet, you see the discharge, we are using not yet to tell that patient will definitely be discharged. Have you gotten it? So the operation side, if you write not yet, you are giving us a confirmation that patient will definitely have a surgery. Do you get it? That's the meaning of the not yet.
Yes.
And that's why we write not yet at discharge, because definitely patients will be discharged. Do you get it? So the best word to use if surgery has not been done for the patient is no operation done. And we use no operation done because even a patient on medical ward, it can be possible an operation can be done. Whilst on an admission, FK can even happen, and all patients in the hospital will have to undergo surgery, including nurses. Your mind should be open, no? Yeah. Something can happen. Everybody in the hospital would have to undergo an operation. That's why we use its language. No operation done. So that one is open. Anything can happen. Once you write not applicable, you are trying to, not applicable is just like not yet. You are trying to tell that for that patient's condition, a surgery will never be done whilst patient is on hospitalization. But a surgery can be done. Accidents can happen. Fire outbreak can even happen. Patients may have to be taken to theater. So that's why we don't write not applicable. You write no operation done. Over here, it's about language. Is that okay? It's not a format. It's about language. Okay, are we good?
Yes.
Good. Then, so quickly, now we are done with the other side. So after you've done all these things, now you have your 8 marks. So after you've done, you have your 4 marks. All these things that we've done. So the personal data, 1 mark. The allergies, half a mark. Routine care, half mark. That is 2 marks. Then the medical records, 2 marks. In fact, if I've taught you before, you lose these 4 marks, I'll be very disappointed. If I've taught you before this 4 marks, you should claim this 4 marks within 2 minutes. If you really go through the process I've given, you should be able to claim this 4 marks. It's like you are going to write exams. So the examiner is telling you that I've dashed you 4 marks for free. Student said, no, I want to go and do the 1 hour thing first before I'll come and take the 4 marks. If you think about this, you can see it's not normal. You take the one that is for free first. The one that is for free, that you are not going to struggle to get. You claim all those ones first. Because see, the patient's problem. So if you really observe the things I'm taking you through, the medical records, the allergies, the routine care, the personal data, you should finish in a space of even 3 minutes. You should be able to finish. Then that means that you have 27 solid minutes, or at least you have 25 solid minutes to do the care plan proper. And you can think. And that one, you realize that you'll be relaxed. Haven't you observed when you do the care plan, the previous format, you can finish the inside of the care plan. Most of you don't even attempt the back. And they take the paper without you writing anything at the back. Haven't you observed? Meanwhile, you could have quickly done all those things. Then you have the rest of the time solely for the patient problem, patient strengths, and the inside of the care plan. Very easy. Very, very easy. Okay. All right, plan proper. Is that okay? Good. So now that we are going to do the care plan proper. Okay. Any question on what we've done so far? Yes. Any question on what we've done so far? Hello? Can you all hear me?
Hey.
Any question
Yes,
on what we've
sir.
done? Yes, please. Ask all your questions today. Today, I'm addressing every issue relating to practicals and case studies. So feel free, ask all your questions. When we finish this, then I'll finish the care plan, everything. When we finish, then now I'll start with the case study. Then I'll now come to the practicals. I'll touch on some key things with the practicals. Then I know I'm done with you for practicals. Then I'll share the video with you guys. Yes, any question?
Sir, please, what's about if your patient that you take is a child with the occupation, what are you going to write?
Oh, you were not here. I mentioned that you add unemployed, or you can write students. Okay, unemployed or students.
Thank you.
Don't write child there, because child is not an occupation. So it's two things. Either you write unemployed or students. If it is, let's say, a newborn, just write unemployed. Is that okay? Or students, unemployed or students. Okay, don't write child, or don't write neonate. Don't write newborn. No, newborn is not an occupation. Is that okay? Good. All right. Any other? Okay, so now we can start with the care plan proper. Now, if a patient is having pain, so we will be going through one problem after the other. So when we take one problem, we will go through the problem, we will look at the strengths, we will look at the nursing diagnosis and how to do the care plan for that problem. Okay, good. Now, if a patient is having a pain is a subjective problem. This is how we write the problem. Patient complains of pain. You can make it complaints or complaints. So patient complains of pain at the lower abdomen. Now, the error most students commit is that they write patient complaints of pain. Please, you'll be marked wrong. Once you write pain, you don't attach the specific area. It's a wrong problem. In fact, there is no problem. Once you didn't specify the area, there is no problem. So patient complains of pain at the lower abdomen. Patient complains of pain at the lower abdomen. Patient complains of pain at the lower abdomen. Patient complains of headache. Patient complains of headache. Now listen, if they give you a hypertensive patient, never ask the patient whether the patient is in pain. Sometimes use their mind. Now, if you are going through the patient's medication treatment chart, a patient is on paracetamol, don't make any attempt to go and question whether the patient is in pain. It's your duty now to find out where the pain is. So look at how you ask it. They were giving you paracetamol. Where is the pain? Okay, you are taking an analgesic. Because if the patient is not in pain, there is no way the doctors will put the patient on painkiller. There is no way the doctors will put the patient on analgesic. So don't go and ask the patient, are you in pain? Patient will definitely say no. The patient will definitely say no, because if they tell you yes, they are thinking you go and write it down. You are writing it in their documents. So they want to tell you they are okay. So you ask it in a smart way. Oh, for some time you were in pain, which I know by now it has come down. Please, where was that pain? Patient will say, oh, that pain there is gone. It was in my abdomen. You get it? Smart way. Okay. But mostly, there are some pains you don't even need to ask. For example, a patient is having a wound. Why are you asking patients whether you are in pain? Why? A patient's surgical ward, patient is having a wound. Why are you asking whether patient is in pain? No, it's not logical. Once the patient is having a wound, that patient is having pain. Do you get it? So there are some times, for example, a patient is having malaria. Why are you going to ask whether patient is having headache? You should know that from literature. A hypertensive patient, why are you going to ask whether patient is having headache? You should know from literature that hypertensive patients, the patient will have occipital headache. You don't ask. And mostly you cross-check. So that's why I tell you, even the patient's medications can give you an idea some of the problems patient is having. The medications. Okay? Good. So a patient is having pain. So I'm teaching you other ways you can use to know patient is having pain, apart from asking the patient. Okay, apart from asking the patient, your knowledge from the conditions too should tell. A patient with chronic renal failure, you should know patients will have headache. A patient with meningitis, you should know patients will have headache. A patient with respiratory problem, you should know patients will have chest pain. You don't ask. You've seen a patient on oxygen. Hey, and nurse is asking, are you in pain? Definitely the patient is experiencing some kind of chest pain or chest discomfort. You don't ask. So there are some things. That's why I say that most people who really know what they are up to in care plan, they don't talk plenty. If you find students talking plenty, they are usually the ones who don't know. So if you go to the exams or during the care plan, the first 30 minutes, you are talking plenty. Remember that Sir said this, that if you are talking plenty, you are not likely to finish. You are not likely to finish. If you cast your mind back, care plan, if you are talking plenty, it means you are pressed down. You don't know what you are up to. Those who know what they are up to and who will finish in time, they don't talk plenty. Is that okay? So patients complain of pain at the lower abdomen. Patients complain of pain. Don't write patient complain of pain at the wound site. Where is the wound site? The pain. We are interested in the location. Where is that wound site? Patients complain of pain at the hand. Where hand? Which of them? Is it right or left? Patient complains of pain at the lower abdomen. Patient complains of pain at the upper abdomen. Patient complains of pain at the right thigh. Patient complains of chest pain. Patient complains of headache. So pain can come in different forms. So just that you should be specific. Okay, you should be specific. Okay. Now, how do you write strengths for pain? Patient can verbalize the intensity and location of pain. Patients can verbalize the intensity and location of pain. How do you write diagnosis for pain in the current NANDA? Yes, how do you write diagnosis for pain? This is how you write the diagnosis for pain. Okay, so you see the dates that I've written. Look at the date. What is the date? 15th July 2025 at what? 8 o'clock a.m. 15th July 2025 at 8 o'clock a.m. Okay, how did I write the diagnosis? Acute pain into brackets, lower abdomen, related to inflammatory process of disease condition. Acute pain, into brackets, lower abdomen, related to inflammatory process of disease condition. Now, remember that the pain, you can also relate it to surgical intervention. For example, those of you who will be going to surgical, if the operation has been done, don't relate the pain to the inflammatory process of disease condition. Relate it to the surgical intervention. Let me repeat that again. When you go to surgical, okay, and they give you a patient whose operation has been done, okay, they give you a patient whose operation has been done, don't relate it to the inflammatory process of the condition. Relate it to the surgical intervention. Acute pain, into brackets, lower abdomen, related to surgical intervention. Acute pain, into brackets, lower abdomen, related to surgical intervention. Please, are we good? But if the patient has not gone for the surgery, then you relate it to inflammatory process. For example, a patient with malaria, you are writing pain, acute pain, into brackets, lower abdomen, related to inflammatory process of disease or infectious process of disease. If a patient with appendicitis, surgery has not been done, don't write acute pain, into bracket, lower abdomen, related to surgical intervention. Surgery has not been done. Oh. You can't relate it to surgical intervention. Those are the petty errors. So if you submit to me appendicitis, surgery has not been done, okay, you've related to it to surgical intervention, I will give you half instead of the full one. I'll give you half. Now, let's look at the objective stroke outcome criteria. Patient's abdominal pain will reduce within 45 minutes, as evidenced by patient verbalizing that pain has reduced and nurse observing patient with a cheerful facial expression. You see how I've written it? You see that formally in case study, do you know how you write it? You write patient's abdominal pain will reduce within 45 minutes, as evidenced by, then you leave semi-comma, then you write A, patient verbalizing that pain has reduced, then B, nurse observing patient. In care plan, you can combine it. In licensing exams care plan, you can combine it as one. Fine. If you also write it the way you write case study onto, it's not wrong. So patient's abdominal pain will reduce within 45 minutes, as evidenced by A, patient verbalizing that pain has reduced, B, nurse observing patient with a cheerful facial expression. That one too is not wrong. Now let's look at the nursing orders for pain. Reassure patient that measures will be taken to relieve pain. How do you write the intervention? Now, with the first 30 minutes, you only write up to orders. With the first 30 minutes, you only write up to orders. Now, when you finish your 2 tasks, then you go straight to the vigilator and tell the vigilator that you are done with your 2 tasks. You want to evaluate.
Hello, sir.
Yes, please. Ask your question, young lady.
Sir, please. I learned the assessment should come before the reassurance.
No. For pain and anxiety, reassurance is the best. But in a situation where your care plan that you are doing, the problems that you've written, you have anxiety and pain, please, the reassurance, reserve it and go and write it under the anxiety as the first. Are you getting it? Now, the point is that someone can also even write orders that assessment will not be part of. Now, remember that the orders, you only have to write at least 3. So someone can also remember only, let's say, what if the person you are talking about or the person doing the exam, the person only remembers employ diversional therapy, assist patients into a comfortable position, check vital signs. There is no order. The point is that you should write the orders. Do you get it? Just that, because in the examination, someone may even remember only 3. Someone may even remember only assist patients into a comfortable position, check vital signs, administer prescribed medication. Does it mean me, the examiner, I should mark the person wrong because the person didn't start with assessment? No. What I'm checking is that the person have written 4 orders. Are we good? The point is that write 4 orders. Okay. But for reassurance, if you are having anxiety and you've already reassured there, or you are having anxiety in your problem, reserve that order, the reassure patient, reserve it rather for what? Reserve that order for for anxiety. Okay, that means that in such a situation, when we come to your acute pain, you start with assess patient's level of pain. In fact, assessment is an order that works for, it's like a bonus order. Every nursing diagnosis, you can do assessment. Every nursing diagnosis, you can do assessment. So I consider assessment as a bonus order. Okay, I consider it as a bonus order, and I'll teach you how we assess for all problems. Is that okay? So all the orders I've written here are the range of orders that you can give for pain. So reassure patient that measures will be taken to reduce pain. Patient was reassured that measures will be taken to reduce pain. Assess patient's level of pain using a scale of 0 to 10. Patient's level of pain was assessed using a scale of 0 to 10, and patient takes 7. Okay, you can even come and write. So initially when we started, Peter even raised a question that why is it that we are saying pain will reduce, the assessment we are having 7, it means pain is there. This is the initial assessment. So some students, what they write is they can write assess patient's level of pain, and then the intervention, patient's level of pain was assessed using a scale of 0 to 10, patient takes 7. Then after they've administered medication, under that last point, they come and do patients reassess patient's level of pain. Then they come and they write patient's level of pain was reassessed, patient take 2. You see how it is. So be smart. Is that okay? So the assessment
please
can
come
even be
again.
okay. So what I'm saying is that you see the first assessment, assess patient's level of pain using a scale of 0 to 10. Patient's level of pain was assessed using a scale of 0 to 10. Patient take 7. Now we've employed diversional therapy. We've assisted patients into a comfortable position. We've checked vital signs. We've administered prescribed medication. Someone can write a last order, reassess patient's level of pain. Then the intervention, patient's level of pain was reassessed using a scale of 0 to 10. Patient take 2. You get it? So you see, the first one was assessed. The second one will come after the administered prescribed medication. Do you get it? That one is very good, especially when you are doing case study. But in this situation, please, there are so many orders. Why are you relying on assess 2 times? There are so many orders. So don't rely on assess. So the assess, you can even choose to do the array assessments. You can even choose to start with assess patient's level of pain using a scale of 0 to 10. Then patient's level of pain was assessed using a scale of 0 to 10. And patient take, let's say, 2. So that everybody look at it will look at it in a sense of the reduction. In a sense that your assessment found the reduction. Do you get it? All right. Any question on the pain? So let's pay attention to something. Look here. The objective stroke outcome criteria. You see the time frame is 45 minutes. That 45 minutes, add it to your time here. You get 8:45. Then you come here, go fully met. You write the same dates that you have over here, the same dates. You write it under it. Then you write the time. Then the 45 minutes that you've added to the 8 a.m., 8:45, you write it under it. Then you write STN. Then your initials. Then you sign your signature. Let me repeat it again. The time frame, you remember that you can't write objective without a time frame. So the time frame that you have over here, the 45 minutes, you add it to the 8 o'clock. It will be 8:45. You add it to the time over here. So if you have 9:20, if you have 8:20, if you have 8:10, you add the 45 minutes to the time here. Over here is 8. 45 minutes to 8 a.m. is 8:45. So here will be 8:45 a.m. Then STN, you write your initials, then you sign under it. Any question on the pain before we move to a different problem? Any question on the pain? Now let's look at a patient who has a surgical wound. Okay, a patient is having a surgical wound. How do we write the problem? Patient has a surgical wound at the lower abdomen. This one is at. Patient has a surgical wound at the lower abdomen. Okay, so patient has a surgical wound at the lower abdomen. Patient has a surgical wound at the lower abdomen. Okay, patient has a surgical wound at the lower abdomen. How do we write the strength? Yes, how do we write the strength? Patient wound is not infected. Patient wound is not infected. Patient wound is not infected. Patient has a surgical wound at the lower abdomen. Patient wound is not infected. Yes, please.
So can you say patient has the items for the
No,
wound
it's not
dressing?
accepted. It's not patient strength.
Okay.
It's not accepted. Okay,
Yes,
patient
please.
wound is not infected. You can even write patient has appetite for adequately nutritious food, because you know, if patient has appetite for adequately nutritious food and is eating properly, okay, then it can help promote wound healing. So you can write patient is adequately nourished. Is that okay? That one too is good. Okay, or patient has appetite for adequately nutritious food. Okay, or patient has access to adequately nutritious food. That one too is a good point. Okay, good. Patient wound is not infected. Okay, now let's look at how we do nursing diagnosis for wound. Okay, so the nursing diagnosis for wound is impaired skin integrity. If you write it and leave it there like that, it's wrong. Impaired skin integrity into brackets, surgical wound at the lower abdomen. Surgical wound at the lower abdomen. So surgical wound at the lower abdomen. Okay, impaired skin integrity into brackets, surgical wound at the lower abdomen, surgical wound on the right hand, surgical wound on the left leg, surgical wound on the right thigh, surgical wound, okay, impaired skin integrity. Remember, if you don't open a bracket and tell us where the wound is, it's wrong. Oh. It's wrong. They can't even give you half. Impaired skin integrity into brackets, surgical wound at the lower abdomen related to surgical intervention. Okay, so it means that this patient, the wound is from what? Surgical intervention. You can have impaired skin integrity into brackets, surgical wound at the lower abdomen related to, let's say, burns, which is the cause. Impaired skin integrity into brackets, surgical wound at the lower abdomen related to, let's say, inflammatory process of disease condition. Impaired skin integrity into brackets, wound at the lower abdomen related to fall. Impaired skin integrity into brackets, wound on the right leg related to fracture. Okay, the cause. Is that okay? Good. Now, do you know that if a patient is having pressure sore, that one too is impaired skin integrity. That is when the pressure sore is there. That one too is impaired skin integrity. When the pressure sore is actually there, that one too is impaired skin integrity. But that one, if you are writing the problem, you don't write patient has a wound at the sacral region. You write patient has a pressure sore at the sacral region. Patient has a pressure sore at the buttocks. Patient has a pressure sore at the calf muscle, a posterior calf. Okay, that is how you write it. Is that okay? But that one, you relate it to maybe a fall or inflammatory process. You relate it to prolonged lying in bed. But still, the diagnosis also impairs skin integrity. I'm talking about when patient is actually having pressure sore, the wound. So impaired skin integrity, you write wound. Impaired skin integrity into bracket, pressure sore at the sacral region related to prolonged lying in bed. Okay, you relate it to surgical intervention. You relate it to inflammatory process of disease condition. You relate it to burns. You relate it to fall. You relate it to prolonged lying in bed. Is that okay? That one is pressure sore. Okay. So impaired skin integrity into bracket, surgical wound at the lower abdomen related to surgical intervention. How do you write the objective to outcome criteria? Patient wound will be cleaned within 45 minutes, as evidenced by nurse observing patient wound looking clean. Patient wound will be cleaned within 45 minutes, as evidenced by nurse observing patient wound looking clean. Patient wound will be cleaned within 45 minutes, as evidenced by nurse observing patient wound looking clean. Okay. Now, let's look at the nursing orders. You see nursing orders here, it starts with assessment. So assessment is like a bonus, but just that how we write it differs. Assess the state of patient wound. The state of patient wound was assessed. In fact, assessment is a bonus order for all problems. assess the state of patient's wound. The state of patient's wound was assessed. Now, set a trolley for wound dressing. Trolley was set for wound dressing. Assist patient into a comfortable position. Patient was assisted into a comfortable position. Dress patient's wound aseptically. Patient's wound was dressed aseptically. Educate and encourage patient to eat foods rich in proteins and vitamins. Patient was educated to eat and encouraged to eat foods rich in proteins and vitamins. Administer prescribed antibiotics. Prescribed antibiotics were administered. Now, a caution I want to give you is that there are times patient is having wound, then the candidate will diagnose risk for infection. Please, it's an error. Patient is having wound. The accurate diagnosis for wound is impaired skin integrity. Patient is having a wound. It's an actual problem. Why are you going to diagnose a potential problem? The wound is there. In nursing diagnosis, we have actual diagnosis, we have potential diagnosis. The wound is there, the problem is there. Why are you going to give a potential diagnosis? Go straight and give the actual diagnosis. Go straight and give us the actual diagnosis. A patient is having wound, don't go and diagnose risk for infection. Whilst the actual diagnosis for wound is there, impaired skin integrity, why are you going to diagnose risk for infection when the actual diagnosis for wound is impaired skin integrity? Is that okay? So please take note of that. That one is an error. Okay, that one too is an error. Yes, please. Ask your question, Juliana.
Sir, please, if the person is at risk of getting the pressure ulcer,
okay,
can you
that
say...
one too, we will come there. That one too, we will come there.
Okay.
If the patient is at risk, that one, the pressure sore is not there. That one, we write the problem differently. That one, we write patient is bedridden. Okay, you write patient is bedridden. This is it. Patient is bedridden. See, patient is bedridden or immobile in bed. Patient is bedridden or immobile in bed. That one, the diagnosis, this is how we write it. You see, risk for impaired skin integrity. Okay, into bracket pressure. Okay. So you see over here, I didn't specify a location of pressure, so I only wrote pressure sore because patient is not having it. So risk for impaired skin integrity into bracket pressure sore related to prolonged lying in bed. That one, you relate it to the same prolonged lying in bed. Do you get it? So that one is a potential diagnosis because patient is not having it. Have you gotten it? And listen, don't write risk for impaired skin integrity. So for example, see, patient is bedridden or immobile in bed. What is the problem? Patient is bedridden. That is the problem. Do you agree? Now, in nursing diagnosis, you see the first part of the nursing diagnosis. It is actually representing the problem, which is patient is bedridden. So you can write risk for impaired skin integrity related to bedridden. It's like you've related the problem again to problem. And that is the error a lot of students commit. Do you get it? That first part of the diagnosis, the first part, the risk for impaired skin integrity, is actually there representing the problem you've written here. And students commit that error a lot when we are talking about loss of appetite. Students commit that error a lot. So they write imbalanced nutrition, less than body requirement, then they relate it to loss of appetite. Meanwhile, if you go to their problem, they've written patient complaints of loss of appetite there. Do you get it? And I'll come to all those things. I'll address all those things later when we are moving on. Is that okay? I'll address all those things later when we are moving on. Okay. All right. Let's move on. Okay. So this is for the wound. So we are done with the wound. So you see that the 40 minutes over here, the time is hot. The time is hot. Within 45 minutes. You see, we've added the 45 minutes to the 30 minutes. Okay, then we come. So go fully met. Then the same date you have over here, you write the date and direct at. If you add the 45 minutes to the 8:30, you get 9:15. So 9:15 a.m. Then you write STN, you write your initials, then you sign and direct. STN, you write your initials, you sign and direct. Let's look at the next problem. The next problem, patient cannot bath and care for his mouth without assistance. Now listen carefully. If patient is having a personal hygiene issue, or a self-care issue, don't write it separately as two. Examiners will mark you together as one. So, for example, patient cannot bath without assistance. Then the smart student shall write, patient cannot bath without assistance. Patient cannot care for her mouth without assistance. As another point, we will mark it one. We will give you 1.5 instead of the 2. It will be considered as one. So put it together. Patient cannot bath and care for his mouth without assistance. If it is only the bathing you want to concentrate on, patient cannot bath without assistance. Patient cannot bath without assistance. Patients cannot bath without assistance. Patients cannot bath without assistance. Now, listen carefully. There are times that this very problem can be written in a different way. For example, let's say they've given you a patient. They've given you a patient. Now, that patient, and you can see clearly the night nurses actually reserve that patient for bathing. Every indicator is showing. Usually, students that they issue them into the care plan the first time. So let's say you reported 8 a.m. The first 2 students, usually, sometimes the nurses have reserved some patients for bathing. Now, if there is a clear indication that patient has not really bathed, you are seeing it, patient has not bathed. And usually the problem is patient has not bathed or patient has not been cleaned. That one is clear. Patient, but maybe you are doing the care plan in the afternoon. Let's say you are doing your care plan in the afternoon. Let's say around 12. Patient has been bathed already in the morning. That one, you can't write patient has not bathed. That one, you write patient cannot bath without assistance. So that one, you are seeing that the patient has been cleaned. But the problem is that during the time of cleaning, patient cannot bath. So that one, you don't write patient has not bathed. Patient cannot bath without assistance. But however the case is, the patient cannot bath without assistance. It works for all the situations. But I'm letting you know the dimensions of how that problem can be written. You can write it that patient has not bathed. You only write it that way when there is a clear confirmation or indicators that patient indeed has not bathed. But however the case is, the patient cannot bath without assistance. It works for all. So I would personally advise you that all the time you write patient has not bathed. Yes, someone wanted to ask a question. Quickly ask it and let's continue.
So, please, if the person can't perform her daily activities,
you can't write patient cannot perform her daily activities. The problem is not specific. Have you forgotten that? We said in nursing process, which is the foundation of nursing care plan, everything you write should be smart. If you write patient cannot perform healthcare activities, what activities are you talking about? It's just like writing patient complaint of pain. What healthcare activity? Is it elimination? Do you know if you say healthcare activity, even elimination is part? Which of them are you talking about? Specify it. All right, patient cannot perform healthcare activity. Patient cannot perform personal hygiene needs. It's not a problem. It's wrong. What personal hygiene activity are you talking about? Specify it. Is it bathing? Is it mouth care? Is it feeding? But what I'm saying is that for the self-care activities, mouth care and bathing, we consider it as one. So if a patient is having that 2 problem, if you are writing, we will consider it as one. But if patient is having patient cannot bath without assistance, patient cannot perform mouth care without assistance, patient cannot eat without assistance, the eating is different on its own. But the bathing and mouth care, we consider it as one in nursing. So don't write patient cannot bath without assistance. Then your second point, patient cannot care for the mouth without assistance. We will mark the 2 as one. So combine it if you find those 2 problems together in the same patient. That's how I've written it together for you to see how it's done. So you don't write patient cannot bath without assistance. Then you come and write your 4th point, patient cannot care for mouth without assistance. The smart student, that's what they do. Is that okay? So that they are trying to tell you when they go to, if you do it that way, when you go to the inside of the care plan, you realize that you are going to have self-care deficit 2 times. The same diagnosis twice. So we always consider them as one. You get, because the diagnosis for the mouth care is the same diagnosis for the bathing. Do you get it? Good. Unless maybe your patient, the patient is not having a problem with bathing, but you think patients cannot perform mouth care without assistance. That aspect too is there. You can have a patient who you per assessment you think is the mouth care that you want to do. So patient cannot care for his mouth without assistance. That one too is a good problem. Is that okay? That one too, the diagnosis is different. No, patient cannot care for the mouth without assistance. The diagnosis is different. No, you see, let me show you the diagnosis for that. The diagnosis for that is this. The diagnosis is different in the current NANDA. The diagnosis is different. See, ineffective oral hygiene behaviors related to general body weakness. Ineffective oral hygiene behaviors. It has changed completely. But in a situation where you combine it with mouth care, this is how you are going to write the diagnosis. This is the current NANDA. We have nothing like partial self-care deficit or bathing self-care deficit or self-care deficit bathing again. In the current NANDA, this is what is there. Decreased bathing and grooming abilities related to general body weakness. Now, anytime you are writing issues with bathing, you can only relate it to general body weakness or body weakness. If you don't want to write general body weakness, write body weakness. This is the only thing you can relate. Don't relate it to fracture. Instead of, we don't want to see medical term in the nursing diagnosis. So instead of relating it to fracture, relate it to, because if someone is having a fracture in the upper limb, the person will have weakness. So relate it to the weakness rather. If a patient is having, let's say, malaria, because of that patient cannot bath, we don't want you to relate it to the medical term. Relate it to weakness rather, because malaria will make the person weak. If a person is having wound on the right hand, and because of the wound, the person cannot bath, the wound has made the person weak. We want you to break it down and relate it to the weakness rather, and not the wound. That's why I say the only thing you can relate problems with bathing and mouth care to is weakness. Either you write general body weakness or simply body weakness. Okay, so this is how you write the problem. Patient cannot bath and care for his mouth without assistance. Then the strength will be patient is very cooperative. You can also write patient can withstand turning in bed for bathing to be done. Patient can withstand turning in bed for bathing to be done. Patient can withstand turning in bed for bathing to be done. Okay, now let's look at how you write the diagnosis. Decrease bathing and grooming abilities. One of you should read for us, please. One of you should read so that I explain. Yes, one of you should read.
Decrease bathing and grooming ability related to general body weakness.
Okay. All right. So you see, in the current NANDA, this is how you write. And you know one interesting thing. In the current NANDA, the decreased bathing abilities related to is different. And then we have what? Grooming, decreased grooming abilities. It's also a different diagnosis. But what I learned from the NANDA is that if you are going to bath patient, can you bath a patient without grooming the patient? You cannot do that. Can you bath a patient and just leave the patient without grooming? So you have to combine those two diagnoses. That's why we have, if you check the current NANDA 2024-2025, okay, we have decreased bathing abilities, different, and we have decreased grooming abilities, different. But there is no way you can go and a patient who cannot bath without assistance, you only do the bathing and not groom. That's why you have to combine it. Decreased bathing and grooming abilities related to general body weakness. Now, we don't write self-care deficit again, please. We don't write partial self-care deficit again, please. That is the old NANDA. In the current NANDA, this is how we write the diagnosis. Decreased bathing and grooming abilities related to general body weakness. Okay. Yes, continue reading. Read the objective. Please read the objective, please. Obaya.
Yes, please. Patients will be assisted to bath and care for her mouth within 45 minutes, as evidenced by a nurse observing patients looking clean and well groomed.
Excellent. Yes, let's do. So have you gotten it? So patients would be assisted to bath and care. You see this one? How I've written this one? I've written it's combined. So meaning in my situation, it means I diagnose both bathing and mouth care. But if your own is just bathing, your objective will be different. So that one will be patient will be assisted to bath and care for. Sorry, patient will be assisted to bath within 40 minutes, as evidenced by nurse observing patients looking clean and patient verbalizing of physical comfort or patient verbalizing of comfort. Is that okay? If you are only doing mouth care, if you are doing mouth care, that one, the diagnosis is different. Or if you looked at only mouth care as a problem, that one, your diagnosis will be this. Your diagnosis, the objective will be the same, but this time your diagnosis will be this one. Your diagnosis will be this one. If your problem, you only focused on only the mouth care alone. Okay, so your problem is patient cannot care for her mouth without assistance. Your diagnosis will be different. Okay, so ineffective oral hygiene behaviors related to general body weakness. Okay, but the objective will be the same. Patient will be assisted to care for her mouth because this is the current nursing diagnosis we have in the current NANDA for mouth care. Ineffective oral hygiene behaviors related to general body weakness. So patient will be assisted to care for her mouth within 45 minutes, as evidenced by a nurse observing patient's mouth looking clean, or patient verbalizing that she's comfortable or her mouth has been cleaned. Patient verbalizing that her mouth has been cleaned. Is that okay? But if you are doing it combined, you stick to the diagnosis for only the bathing. Okay, and that will be decreased bathing and grooming abilities. And I said, anytime you are writing the diagnosis for bathing, do the bathing and grooming combined. Decreased bathing and grooming abilities related to general body weakness. Is that okay? Good. So nursing orders will be assess patient strength. You see, assessment is coming first. Assess patient strength. Is that okay? Patient strength was assessed and she was partially active and she was passive. You get it? And remember, you've done the assessment of their strength already under the routine care. Is there, so you already have an idea. Okay, set a trolley for bed bathing and oral care, because I am doing a combine. I am looking at the mouth care and bathing. A trolley was set for bed bathing and oral care. Bath patient systematically. Patient was bathed systematically. Treat patient pressure areas. Patient pressure areas were treated. Is that okay? Please, can you all see that? Patient pressure areas were treated. Okay, good. The next thing is explain the importance of personal hygiene to patients. The importance of personal hygiene was explained to patients in the past. Change soiled bed linen from side to side. You see, and one thing about writing the orders is that anytime you are writing an order, have in your mind the domain or the scope of your range of tasks based on your background. So if you are a registered nurse, what are your domain of tasks, and which of the tasks or the procedures revolve around the problem you've written? So you see, patients who cannot bath, you can treat pressure areas. So pressure areas is actually a strong point under this. Okay, so you see, so the examiner can look through and give you bed bathing, give you treating pressure areas, and also give you changing soiled linen from side to side. So change soiled linen from side to side. You can even write change soiled linen. You can just write change soiled bed linen. Change soiled bed linen. Simple as that. No need to add a side to side. Is that okay? So assess patient strength. Patient strength was assessed. Set a trolley for bed bathing and oral care. A trolley was set for bed bathing and oral care. Bed bath patient. Patient was bed bathed. Treat patient pressure areas. Patient pressure areas were treated. Explain the importance of personal hygiene to patient. The importance of personal hygiene was explained to patient. Change soiled linen. Soiled linen was changed from side to side. You see how it is? Very interesting. Very, very interesting. Now look at the time. Patients will be assisted to bath and care for her mouth within 45 minutes. You add this 45 minutes to the 750, you get 835. Okay, so you write the same date you have over here. You write it under go fully met. You write the same date under. You write your at. You write your 8:35 a.m. STN. You write your initials, then you sign under it. You are done. Okay. Let's move on to the next problem. Patient is anxious of the outcome of condition and hospitalization. So here we are looking at a patient who is anxious. Patient is anxious of that. Now listen, never write patient is anxious. Please, oh, it's wrong. If you write patient is anxious of what? Patient is anxious of what? Patient is anxious of what? Never write patient is anxious. Anytime you are writing anxiety, remember today. Never write patient is anxious. It's wrong. Patient is anxious of the outcome of condition. You all the time stick to patient is anxious of the outcome of condition. There are times you have to write patient is anxious of the impending surgery. Okay, there are times you have to write patient is anxious of the impending surgery. Okay, but however the case is, even if patient is anxious of the impending surgery, still, patient is anxious of the outcome of condition still applies. Okay, so you all the time stick to patient is anxious of the outcome of condition. Patient is anxious of the outcome of condition. Please and please and please do not write patient is anxious. Do not write patient is anxious. Do not write patient is anxious. Patient is anxious of the outcome of condition. Patient is anxious of the change of environment. Patient is anxious of the outcome of condition. Patient is anxious of the impending surgery. Patient is anxious of absence from her workplace. Okay. Patient is anxious of his absence from school. Why is the patient anxious? Indicate it. How do we write the strength? Patient can express his fears and worries. Patient can express his fears and worries. Patient can do what? Can express his fears and worries. Patient can express his fears and worries. Patient can express his fears and worries. Patient can express his fears and worries. Very simple. Patient can express his fears and worries. Patient is anxious of the outcome of condition and hospital. Patient can express his fears and worries. Let's look at that for education. Patient has inadequate knowledge on hernia. You see, I didn't write condition. And if you write condition, you have to open a bracket and write the condition, the diagnosis that you wrote. You already know the patient diagnosis. So patient has inadequate knowledge on hypertension. Patient has inadequate knowledge on hernia. Patient has inadequate knowledge on appendicitis. Patient has inadequate knowledge on thyroidectomy. Don't write patient has inadequate knowledge on condition. It's wrong. It's not specific. Patient has inadequate knowledge on condition. Anytime you are writing a problem, ask yourself, the problem I'm writing, is it specific? Patient has inadequate knowledge on condition. Okay, so you see over here, patient is willing to be educated on condition. You can open a bracket and add hernia. Patient is willing, that's the strength. Patient is willing to be educated on hernia. Patient is willing to be educated on the causes of hypertension. Patient is willing to be educated on hypertension. Patient is willing to be educated on stroke. Patient is willing to be educated on meningitis. Patient is willing to be educated on hernia. Patient is willing to be educated on appendicitis. You get it? Good. Let's go and look at it. Yes, Peter.
Sir, please, is it always that you have to do patients has inadequate knowledge on hernia? Can you also say patients has inadequate knowledge on National Health Insurance Scheme?
No. In education, we don't have any procedure like educate patients on national scheme. Do you know that? We don't have any procedure like that. Now, the idea with writing the problem is you are writing a problem to attract a domain of tasks within your background as a registered nurse, as a public health nurse, as a midwife. There is no tax like educate patients on national health insurance. The tax is straight education of patients on condition. Did you realize that? Yes. So you can't decide to educate patients on national health insurance scheme or patient has inadequate knowledge on national health. No, it's the condition straight. Okay, and in educating patients on condition, you can choose to do all those things in addition. Do you get it? So patient has inadequate knowledge on condition straight. You can even write patient has inadequate knowledge on the risk factors and preventive measures of hernia. Straight, specific. Okay, good. Yeah, so if you are writing inadequate knowledge, the focus is on condition, not on any other thing. Don't say patient has inadequate knowledge on hospital protocol. No, that is not what the domain of task focuses on. Okay, so the idea with the inadequate knowledge, anytime you are writing a certain problem, you have a certain intervention in mind, though. You have an intervention within your domain in mind. Do you get it? You have an intervention within your domain of tasks for the exams you are going to write in mind. Are you getting it? That's the foundation of how you write the problem. All right, so let's go back to the table. Now, for anxiety, now this is how you write the current NANDA. This is the diagnosis for anxiety. Excessive anxiety is no more anxiety. It's no more anxiety. In the current NANDA, please, it's no more anxiety. It's excessive anxiety. Please remember, in the current NANDA, we don't have anxiety. It's excessive anxiety related to unknown outcome of condition. Okay, excessive anxiety related to unknown outcome of condition. You see here, we didn't relate it to anxiety. See, did you realize that excessive anxiety related to unknown? We didn't relate it to the anxiety. Did you realize that? So always be careful. The first part of your diagnosis, the nursing diagnosis, actually represents the problem. You see, the patient problem is patient is anxious of the outcome of condition. So this is the cause. So you see, the first part, excessive anxiety. You see, we didn't relate it to anxiety again. Excessive anxiety related to unknown outcome of condition, or you can relate it to impending surgery. That is, if it is an impending surgery. You can also relate it to change of environment. You can also relate it to hospitalization. Is that okay? Excessive anxiety related to unknown outcome. Don't write excessive anxiety related to anxiety or related to patient being anxious. That anxiety is representing your problem, so you can't relate problem to problem again. Okay. Now let's look at the objective to outcome criteria. Patient's level of anxiety will reduce within 40 minutes. Don't use relief. Now, first, there was a confusion over there. People were thinking we can relieve anxiety. No, you can't. So you can reduce it. That is why now the current NANDA has come to make it clear, excessive anxiety, to tell you that you can better reduce and not relieve. Okay, so patient's level of anxiety will reduce within 40 minutes, as evidenced by patient verbalizing that he is no more anxious, nurse observing patients looking calm in bed. What are the others? Reassure patients of the competency of health team. Patient was reassured of the competency of health team. Assess patient's level of anxiety. Patient's level of anxiety was assessed. Explain the need for hospitalization to patients. The need for hospitalization was explained to patients. Introduce patient to other patients with similar condition who have recovered successfully. Patient was introduced to other patients with similar conditions who have recovered. Allow patient to ask questions and answer patient questions tactfully. Okay, here it's not quietly, it's tactfully, and answer them tactfully. Okay, so allow patients to ask questions and answer them tactfully. Patient was allowed to ask questions and they were tactfully answered. Okay, so now look at the time. You see, the time over here was 8 a.m. We add the 40 to the 8 a.m. Then we have 8:40 a.m. So STN, SAJ, then you sign under it. STN, SAJ, then you sign nicely under it. You sign nicely under it. Is that okay? Good. Now let's look at, now in the current NANDA, we don't have anything knowledge deficit. Peter and your people, we don't have anything knowledge deficit. Peter, when was the last time you wrote knowledge deficit? Peter, when was the last time you wrote knowledge deficit or deficient knowledge? Obaya, when was the last time you wrote deficient knowledge or knowledge deficit? When was the last time? Okay, so those of you who wrote it not long ago, please, you can write it again. In the current NANDA, we don't have anything like knowledge deficit. Now, what is there is inadequate health knowledge. This is the new diagnosis, nursing diagnosis for knowledge. Inadequate health knowledge. Inadequate health knowledge related to lack of exposure to disease condition. Inadequate health knowledge related to lack of exposure to disease condition. You see, I've opened brackets and I've written hernia. Inadequate. Don't write inadequate health knowledge related to inadequate knowledge on condition. You've related problem to problem again. Remember, this inadequate health knowledge is representing patient has limited or inadequate knowledge on condition. Okay, so inadequate health knowledge related to lack of exposure to disease condition. How do we write the objective? Patients would gain adequate knowledge on condition within 40 minutes of education, as evidenced by nurse observing patients, correctly answering questions asked on condition. Patients would gain adequate knowledge on condition within 40 minutes of education, as evidenced by nurse observing patient, correctly answering questions asked on condition. Now, the nursing orders: assess patient's knowledge on condition. Nursing intervention: patient's knowledge on condition was assessed. Educate patients on condition in a language he understands. So here is he. Let me not use we. Educate patients in a language he understands. So educate patients in a language he understands. Okay, so educate patients in a language he understands. Patient was educated on the condition in a language he understands. Okay, so please take note of that. Now, the next thing is educate patients on the causes, risk factors, signs and symptoms, and preventive measures of condition. Patient was educated on the causes, risk factors, signs and symptoms, and preventive measures of condition. Is that okay? Allow patient to ask questions. Patient was allowed to ask questions. Answer patient questions tactfully. All patient questions were tactfully answered. Is that okay? Any question on the knowledge and anxiety? Please, any question on knowledge and anxiety? Let's do that quickly. Then the time frame is what? 40 minutes. If you add 40 minutes to the time over here, 8:40. So you write go fully met, 8:40. You write your time, STN, you sign. You write your initials, then you sign under it. Okay, let's go to the next set of problems. Someone should read, please. Someone should read. Let's go to the next set of problems.
Patient is bedridden or immobile in bed.
Okay. How do you write the strength for that? Yes, how do you write the strength for that? Hello? Oh, let me hear from you. It's on the slide, though.
Patient can tolerate too early turning in bed or well hydrated.
Good, excellent. Good. So that's how we write. Okay, so read all the problems. So then we go to the table straight. Read all the problems. Let's be very quick so that I can do the
patient's problems. First one, patient is bedridden or immobile in bed. 2. Patient's urethral catheter has not been cleaned. 3. Patient cannot eat without assistance or patient has not eaten.
Okay.
4. Patient's linen is unkempt. 5. Patient has not been tube fed or patient has difficulty swallowing.
Okay.
And then the patient's strength. We have patients can tolerate too early turning in bed or well hydrated.
Okay.
Patient is not infected. Catheter is patent and well placed or well tolerated.
Okay.
3. Patient can sit up in bed and has appetite for food.
Okay.
4. Patient is very cooperative.
Okay.
5. Patient's NG tube is patent and well placed.
Okay. That's fine. So these are some different problems and their corresponding strengths. So if you are writing patient has not been tube fed, you don't write patient has NG tube in situ. Patient has NG tube in situ. Remember, it's not a problem. If you tell us patient has NG tube in situ is a problem, then it means the health professionals has given the patient problem. It's not a problem. It only becomes a problem when the patient has not been tube fed. So patient has not been tube fed. That is when it becomes a problem, meaning patient has not been given tube feeding. Okay, that is when it becomes a problem. Okay, but the NG tube being in situ is not a problem. Okay, then the strength for that is patient's NG tube is patent and well placed. That is a strength. Is that okay? Another problem that we mentioned on this slide is patient bed linen is unkempt. Okay, patient is very cooperative. In fact, this feed problem, patient bed linen is unkempt. You rely on it when you are pressed in a situation where you don't remember anything. You are not getting any problem. Then you can rely on these very problems. Okay, I'll explain how we do all that. So let's go to the table quickly.
Hello, sir.
Yes, please.
Yeah, please, when the patient is unconscious, can you write, can you use the first problem, which is the patient is bedridden?
Yes, you can use it. Usually that problem works very well for unconscious patients. Usually, it works very well for unconscious patients. Is that okay? Good. And mostly, if you write that problem, do you know if I'm examining you and you write that problem, do you know what I'll go and check? I'll quickly go to your routine care and go and check whether you wrote passive or active. And I'm expecting to see passive there. You get it? If you write that problem quickly, I'll go to your routine care, go and check the activity and see what you wrote there. And I'm expecting that you wrote passive over there. Because mostly this problem, you find this problem a lot in passive patients. Is that okay? Good. Yes. So look, you see, you can't write patients has urethral catheter as a problem. Please. So remember, you can't write patient has urethral catheter as a problem. It only become a problem when it has not been cleaned. So don't go and write patient has urethral catheter in situ. It's wrong. It's not a problem. Then that problem, we the nurses gave you to the patient too. Have you thought about that? So if you write patient has urethral catheter in situ, it means we the medical people, we give that problem to the patient. It becomes a problem when it has not been cleaned. Patient's urethral catheter has not been cleaned. That is when it becomes a problem. Okay. Patient cannot eat without assistance or patient has not eaten. Patient cannot eat without assistance or patient has not eaten. Patient cannot eat without assistance or patient has not eaten. Are we good? All right, let's move on. So look at this. You see, we've done the pressure sore already. So risks for impaired skin integrity into bracket pressure sore related to prolonged lying in bed. Okay. Now, what are the objectives to outcome criteria? Patient pressure areas will be treated within 45 minutes, as evidenced by nurse observing patient pressure areas being treated and looking intact. Okay. Nursing orders. Assess patient pressure areas. You see, assessment is here again. Patient pressure areas were assessed. Set a trolley for treatment of pressure areas. A trolley was set for treatment of pressure areas. 3. Treat pressure areas every 4 hours. Pressure areas were treated every 4 hours. Change patient position every 2 hours. Patient position in bed was changed every 2 hours. Encourage patient to take in adequate fluids. The intake of adequate fluids was encouraged. 6, change soiled linen from side to side. Soiled linen was changed from side to side. You see how simple it is. Then you add the 45 minutes. Here we have 8.5. If you add 45 minutes to 8.5, you get 8.50. Then you write STN. You write your initials. You sign under it very nicely. You get it. Then you are done. Okay, let's look at the catheter. This one, you can do risk for infection related to uncleaned urethral catheter. Risk for infection related to unclean urethral catheter. Risk for infection related to unclean urethral catheter. So here is what I was explaining. So listen carefully. See, this is the dynamics. Let me teach you something new here. Anytime you diagnose a risk problem, okay, you relate that diagnosis to the problem that you wrote. So what problem did we write? Patient urethral catheter has not been cleaned. In nursing diagnosis, if you have a potential diagnosis, you always relate the potential nursing diagnosis to an existing problem. The existing problem is patient urethral catheter has not been cleaned. So the potential diagnosis is risk for infection. Then you relate it to an existing problem. So when you are diagnosing a potential nursing diagnosis in nursing, you relate the potential nursing diagnosis to an existing problem. So I see people writing, some of them will go and write under the problem side, and they will write, patient is at risk of infection at the problem side. It's wrong. If you are diagnosing a risk problem, you have to tell us the existing problem. Then you relate that nursing diagnosis to the existing problem. Do you get it? You relate the nursing diagnosis to that existing problem. So you see the bedridden, for example, risk for impaired skin integrity. You see, we related it to the existing problem, related to prolonged lying in bed, which is the bedridden. Do you get it? Don't go and write at the problem side, risk for infection. It's not a problem. If you write risk for infection, it's not a problem. Write the actual problem itself, then you can write the diagnosis, then you relate the diagnosis to. So we always relate potential problems or risk problems to an existing problem. And when you are writing the problem, you write that existing problem as the problem. Okay, so that is it for it. All right, so let's move on to the next. So look at how you wrote the objective stroke outcome criteria. Patient urethral catheter will be cared for within 45 minutes, as evidenced by nurse observing patient urethral catheter looking clean. You see, patient urethral catheter will be cared for within 45 minutes, as evidenced by nurse observing patient urethral catheter looking clean. Patient urethral catheter would be cared for within 45 minutes, as evidenced by nurse observing patient urethral catheter looking clean. Nursing order set a trolley for to care for urethral catheter. A trolley was set to care for urethral catheter. You can even add assessments. You see, assess the patency of urethral catheter. You see, assessment is here. The patency of urethral catheter was assessed. Clean patient urethral catheter. Patient urethral catheter was clean. Monitor fluid intake and output. Okay, or record fluid intake and output. Fluid intake and output was monitored and balanced within 24 hours. Administer prescribed antibiotics. Prescribed antibiotics, IV ceftriaxone, 750 milligrams were administered. Encourage patients to take in adequate fluids. Adequate fluid intake was encouraged. Then you see the time over here, 45 minutes. You add it to the time over here, the time against it over here, the corresponding time. Then you come and write the same date you have over here, the same date over here. So go fully met, the same date over here. Then you write the time, STN, then you sign your initials, then you sign. This is how we write diagnosis. Please and please and please. This is how you write diagnosis for patients on urethral catheter. This is how you write the problem. This is the only problem you can write. Patient urethral catheter has not been cleaned. Patient urethral catheter has not been cleaned. Don't write risk for infection. And don't write patient has urethral catheter in situ. It's not a problem. Okay, good. Let's move on to the next one. Now, this is the current diagnosis for how we write. See, patient cannot eat without assistance, or patient has not eaten. This is how you write the problem. You can write it any of these ways. Patient cannot eat without assistance. Patient has not eaten. I will advise you that all the time, do the patient has not eaten. Now, this one is not the same or is the same as loss of appetite too. Please and please and please. This is different. This one is when, for example, patient is weak or a passive patient. Patient is having a problem with, let's say, the upper limb. Patient has not eaten or patient cannot eat without your assistance. This one is different from loss of appetite. So don't go and write loss of appetite and come and write this diagnosis for it. Okay, so this one, the diagnosis, decreased feeding abilities. This is what we have in the current NANDA. Decreased feeding abilities related to weakness. You see, I told you that all self-care problems, you can only relate it to weakness or body weakness. Decreased feeding abilities related to weakness in the upper limbs. Decreased feeding abilities related to weakness in the upper limbs or body weakness. Decreased feeding abilities related to weakness in the upper limbs, or you can relate it to body weakness. Okay, now what are the objectives? Patients would be spoon-fed within 30 minutes, as evidenced by nurse observing patient tolerating about 70% of food served. Patients will be spoon-fed within 30 minutes, as evidenced by nurse observing patient tolerating about 70% of food served. What are the nursing orders? Assess patient's appetite for food. Patient's appetite for food was assessed. Set a trolley for spoon feeding. Set a tray for spoon feeding. A tray was set attractively for spoon feeding. Assist patient into a sitting up position. Patient was assisted into a sitting up position. Serve patients and encourage her to eat. Patient was spoon fed and encouraged to eat. Remove all nauseating articles from her bedside. All nauseating articles were removed from her bedside. Plan diets with patient, family, and dietitian. Patient diet was planned with her family and dietitian. Okay, you can, if you are lacking points, you can even add educate patients on nutrition and diet. Educate patients on proper nutrition and diet. Is that okay? If you are lacking points over here. Okay, the same way you add the 30 minutes to the time over here, you get 8:30. You write STN, you write your initials, you sign nicely under it. Okay, now let's look at the next one. You see this one? You see this one? This one is also different. Let's look at the problem. Let's look at the problem. Okay, so risks for imbalanced nutrition, less than body requirements, related to difficulty swallowing or inadequate nutrition intake. Risks for imbalanced nutrition. This one is for the loss of appetite too. No, sorry. This one is for NG2. Sorry, this one is for NG2. But I'll come to the loss of appetite. This one is for NG2. So NG2, look at the problem. Patient has not been tube fed or patient has difficulty swallowing. You see how we wrote it. Patient has not been tube fed or patient has difficulty swallowing. Please write it combined this way. Write it combined, the two this way. Patient has not been tube fed or patient has, always write it combined this way. I prefer you write it the two this way. Patient has not been tube fed or patient has difficulty swallowing. Combine like this. Okay, now let's do the diagnosis. Risks for imbalanced nutrition, less than body requirements, related to difficulty swallowing or inadequate nutritional intake. Write it exactly like this. Now, objectives to outcome criteria. Patient will be tube fed within 40 minutes, as evidenced by nurse observing patient being tube fed. Okay, assess for correct placement of NG tube. The correct placement of NG tube was assessed. Assist patient into a sitting up position. Patient was assisted into a sitting up position. Tube feed patient. Patient was tube fed. Plan patient's diet with patient, family, and dietitian. Patient's diet was planned with patient, family, and dietitian. Monitor patient's fluid intake and output. Patient fluid intake and output was monitored. Assess patient's nutritional and hydration status. Patient's nutritional and hydration status was assessed. Simple as that. Okay. Now the last one, the one that I told you it can save you. Patient bed linen is unkempt. Okay. This is how you write the diagnosis. Impaired physical comfort related to unkempt bed linen. Impaired physical comfort related to unkempt bed linen. impaired physical comfort related to unkempt bed linen. Patient dirty linen would be changed within 35 minutes, as evidenced by patient verbalizing that she is comfortable and nurse observing her looking clean. Now, the strength. Assess patient strength. Patient strength was assessed. Set a trolley for changing dirty bed linen. A trolley was set to change dirty bed linen. Change dirty bed linen from side to side. Dirty bed linen was changed from side to side. Assist patient into a comfortable position. Patient was assisted into a comfortable position. Explain the importance of personal hygiene to patient. The importance of personal hygiene was explained to patient. The time frame is 35 minutes. You add it to the 8 o'clock, you get 8:35. STN, you write your initials, then you sign under it nicely like this. Now let's go to different sets of problems. One of you should read. You mention the problem, you tell us the corresponding strengths. These are also different sets of problems. Yes. Let's do it quickly. Then I can take you through the case study. Then I can
Patient
do the
has
practical.
a high body temperature. It's bracket 38 degrees Celsius. Patient strength. Patient is well hydrated, cooperative, and able to report discomfort or symptoms.
Okay. All right. So that is how we write the problem. So patient has a high body temperature. You see how I've written it. Now, one thing about body temperature is, listen, if you are going to diagnose body temperature, it should be by your own check. Do you realize that that can take your time? The first question is that, do you have a thermometer with you, or you go to the station and go and bring thermometer? In fact, if I'm an examiner, you write patient has a high body temperature, I will confirm. I'll confirm 2 ways. Did you do the checking yourself, or it was done and documented and you recorded it or you wrote it? Ideally, if you are writing this problem, the check should be your own check. The check. In fact, the practical exams, one of your dress code, thermometer and scissors should be part of your dress code. Thermometer and scissors, it should be part of your dress code. Is that okay? In addition to your lab coat or those doing diploma, your apron, thermometer and scissors should be part of your dress code. So if you are writing this problem, the check should be your own check. But sometimes you have to be smart. Sometimes it's very obvious that a particular patient, the issue they are addressing is about. The issue they are addressing is actually about it's actually about high body temperature. So sometimes you hear the patient is spiking, this patient is spiking, such a situation, fine. Then you can reference. But ideally, if you are writing this problem, the check should be your own check. And you realize that this problem is like going to do money ritual. You can't write this problem without wasting 1 minute of your time in the exams. Do you agree? You can't waste 1 minute. You can't write this problem without wasting 1 minute of your time, because you use 1 minute to check the temperature. Yes, you use 1 minute to check the temperature. So if you are writing this problem, it means you've accepted to waste 1 minute of your time, because you have to be the one to check. And if you are the person that is not even having thermometer, then you have a problem. It means you have to go to the nursing station, and that will be accounting for about 2-3 minutes of your time. Okay, that's fine. So patient has a high body temperature. Then you have to, if you write patient has a high body temperature, it's wrong. You can't also write patient has fever. It's wrong. Patient has, this is the right way of writing the problem. Patient has a high body temperature. Then you specify that high body temperature. Patient has a high body temperature into bracket 38 degrees Celsius. Patient has a high body temperature. Then you write, this is the strength. Patient is well hydrated, or you can write, patient is able to report discomfort or symptoms. Patient is able to report discomfort or symptoms. Or you can write, patient is well hydrated and able to report discomfort or symptoms. Okay. Let's look at the second one. Patient cannot clean her mouth. We've looked at this already. Patient cannot clean her mouth without assistance, or patient's mouth has not been cleaned. Patient complains of dizziness. Okay, so patient cannot clean her mouth. This is the strength. Patient is very cooperative and willing to receive assistance with oral hygiene. Now, the patient complains of dizziness. Patient is conscious, alert, and able to request support when feeling dizzy. Now, let's look at the fourth. Patient complains of difficulty sleeping. Patient complaints of difficulty sleeping. Patient complaints of difficulty sleeping. Patient complaints of difficulty sleeping. What is the strength? Patient is mentally oriented and open to relaxation, guidance, and education. Let's look at the feed. Patient complains of or has difficulty breathing. Either you use patient complaints of or patient has difficulty breathing. Any of them works. So patient maintains a clear airway and responds appropriately to oxygen therapy. You can write, patients can assume a sitting up position. Patients can assume a sitting up position. Okay, patient can assume a sit, or patient can withstand a sitting up position. Okay, now let's go to the tables. We've done this one already. Ineffective oral hygiene B. That is if the problem you are concentrating on is specifically only the oral care or the mouth care. That one, the objective will be patient to be assisted to care for her mouth within 45 minutes, as evidenced by nurse observing patient's mouth looking clean. Assess patient's ability to cooperate with oral care. Patient's cooperation and consciousness level were assessed. Set up a clean tray with materials for mouth care. A clean tray with materials for mouth care were prepared. Assist patient into a comfortable sitting or sidelining position. Patient was positioned comfortably in a foul-less position. Perform oral care. Oral care was performed. Inspect the oral cavity for lesions, dryness, or odor. Oral mucus was inspected and found to be free from sores or plaques. Educate patients on the importance of regular oral hygiene. Patients was educated on the benefits of daily oral hygiene. You add the 40 minutes to the 9:10, you get 9:55 a.m. STN, you write your initials, then you sign. Now let's look at how we diagnose the high body temperature. Hyperthermia, into brackets, you state the temperature related to infectious process of disease. All the time, this is how you write it. Hyperthermia, into bracket 38 degrees Celsius, related to infectious process of disease. Now look at how we write the problem. The objective, patient body temperature will reduce to normal range, or you can write patient body temperature will reduce by 1 degree Celsius within 2 hours or within 50 minutes or within 1 hour, as evidenced by thermometer reading and patient verbalizing relief from heat symptoms. Patient body temperature will reduce by 1 degree Celsius, or patient body temperature will reduce to normal range within 2 hours, as evidenced by thermometer reading and patient verbalizing relief from heat symptoms. Nursing orders: monitor and record the patient's temperature every 30 to 60 minutes. Then, patient temperature, body temperature was monitored hourly. Initial reading was 38 degrees Celsius. Now, the next one, encourage oral fluid intake to prevent dehydration. Patient was encouraged and assisted to drink adequate fluids. Provide tepid sponging or cooling measures as needed. Tepid sponging was performed to aid heat dissipation. Keep patients in a well-ventilated and lightly clothed environment. The room was kept cool, and patient was dressed in light clothing. 5. Observe for signs of complications, chills, sweating, confusion. Patient was monitored for shivering and changes in mental status. None noted. Administer prescribed antipyretics. Prescribed antipyretics was administered. This is very simple. Is that okay? Now let's look at the dizziness. This is how you write the nursing diagnosis for dizziness. So, risk for what? Adult or child fall. If you are dealing with adults, don't write risk for fall. So there is nothing like that in the NANDA. Risk for adult falls related to disease process. Risk for adult falls related to disease process. Objectives to outcome criteria: patient would remain free from falls during the shift, into brackets 8 hours. You see, I didn't end that during the shift. I've stated the time, into brackets 8 hours, as evidenced by nurse observing patients, maintaining safety with no physical injury. Patient will remain free from falls during the shift. I've stated the time, 8 hours, as evidenced by nurse observing patients, maintaining hot safety with no physical injury. Nursing orders: assess the level and frequency of dizziness. Patient was assessed for dizziness, intensity, and duration. Monitor vital signs regularly, especially blood pressure and pulse. Vital signs were monitored. Blood pressure and pulse remained within normal limits. Keep call bell, okay, or keep a bell within patient's reach and educate patient to call for help before moving. Patient was educated to use the call bell and avoid sudden movements. Assist patients with all movement, getting out of bed, walking, using toilets. Assisted patients to sit slowly and ambulate safely to the bathroom. You see here is past tense. Assisted patients, meaning we assisted patients, or patient was assisted to sit up slowly and ambulate safely to the bathroom. Ensure the environment is free from clutter and slip hazards. Dry floor, no obstacles. Room was organized to ensure hazard-free environment. Now, place patients in a low bed with side rails up if needed. Patient's bed was kept low and side rails were raised as a preventive measure. Okay, then the evaluation goal partially met. Okay, usually if you write this problem, you do go partially met. Anytime you are writing this problem, you usually do go partially met. Then the 8 hours, when you add the 8 hours to this, you definitely get something like, so let's say 8 hours. If you add 8 hours to 8 a.m., what are you going to get?
4 p.m.
4 p.m. Good. So here is supposed to be 4 p.m. Okay, so that is it. All right. Now let's look at the next. The difficulty sleeping, ineffective sleeping pattern related to change in environment. Ineffective sleeping pattern related to change of environment or change in environment. Ineffective sleeping pattern related to change of environment or change in environment, or disturbance in environment or stress. You can even relate it to pain. Ineffective sleeping pattern related to pain, related to change of environment, related to disturbance of the environment. Patient sleeping quality would improve. Look at the word that I'm using now. Don't use restore. Please, do not use restore. You see, look at, I'm using what? Improve. Patient sleeping quality would what? Improve. I didn't use restore. You can't restore patient sleeping within 5 hours. So patient sleeping quality would improve within 5 hours, as evidenced by nurse observing patients sleep uninterrupted for at least 4 to 5 hours. Assess the patient's sleep habits, bedtime routine, and any underlying stresses. Patient sleep pattern, factors affecting sleep were assessed. Encourage patient to avoid caffeine or stimulants close to bedtime. Patient was advised to avoid coffee or tea in the evening. Promote a quick, dark, and comfortable sleeping environment. Room was dim, noise minimized, and bedding adjusted for comfort. Encourage relaxation techniques such as deep breathing or listening to soft music. Patient was guided through deep breathing exercise before bedtime. Limit interruptions during sleep, like checking vital signs. Okay, so you organize all nursing activities and perform them at a go. It's also a good point over here. Then you administer prescribed sleep aids or sedatives when they are prescribed. Is that okay? Great. Yes, please.
Please, I learned Milo tea induces sleep.
It induces sleep, eh? All those things will come under. You see, I mentioned that. You see, I mentioned that administer prescribed sleep aids. You look at that word. You see, I was very careful with how I drafted it. Sleep what? Aids. So if you think Milo aid is one of them, you can write it at the intervention that Milo tea was set. You get it? So if you think Milo tea, I have not read any literature on that. But if you think Milo tea, you are very positive it's one of the things that can promote sleep. Then, under the intervention for that, you add it to it. Is that okay? Good. So, administer prescribe. So that one, your own will be prescribe sleep aids. Then you add at the intervention side, sleep aids, including Milo drink and so drink was administered or was served. Are we good?
Yes, sir. Thank you.
Excellent. All right, let's look at, these are the last set of problems that I have for you. The last set of problems. Okay, sometimes I see students write patient complaints of general body weakness. You can write a strength. Patient is conscious and able to express needs clearly. Some students also write patient has or complains of difficulty breathing. Okay, good. You can add patient has edema at the lower abdomen, left leg, or swollen feet. Okay, so now let me add this one. Patients complaints of loss of appetite. Okay, so patient complaints of loss of appetite. What strengths are you going to give it to loss of appetite? Patient complaints of loss of appetite. What strengths do you people usually write? You can do patient is very cooperative. Okay, so you can do patients is very cooperative and can tolerate foods in bits and can eat foods in bits and at frequent intervals. Is that okay?
Sir, can you, when it comes to a child,
okay,
can you say patient could eat 4 spoons of food being served to her?
Then that patient has not lost appetite. The moment you start giving a percentage, then you are contradicting the problem you've written.
Oh, okay.
Because sometimes I see a student will write patients complaints of loss of appetite. You come to the strength, then patients can eat 40% of share. Someone can eat 40% of food served. You said you are talking about loss of appetite. Maybe someone's 40%. Do you know someone's 40% of food eating is someone's 100%? For example, we've served food. You don't give us the description of the food. You serve food. Someone's plate of food the person will eat at a meal is about half of what someone will eat, and the person is satisfied and having appetite. So if you are not careful and you go and write patient complain of loss of appetite, patient can tolerate 40% of food served. Hey, a patient can even tolerate 30%. That patient has good appetite. So be careful not to be giving some kind of percentages. Either than that, you contradict the problem you've written. Is that okay? That's why you always have to be careful when you are writing a strength for loss of appetite. Okay, so that you don't go and contradict the problem you've written. So don't even go and mention anything about eating. No. You see here, I wasn't specific. You see, I even used the word bit. I didn't state any percentage, whether the patient is going to eat a certain amount. I was careful with the word I chose. Patient can eat foods in bits and at frequent intervals. Is that okay? Good. But later on, if you guys figure out a different strength or any recurring strengths people have been using and they accepted, we can have a discussion on that. And maybe I can update my slide. Okay, that is fine. Now, so we have loss of appetite too. Okay, now let's look at the problem. Look at this. So ineffective breathing pattern related to airway obstruction or inflammatory process of this. That's for patient complaint of difficulty breathing. That's the diagnosis. Ineffective breathing pattern. So patient breathing pattern would improve within 4 hours, as evidenced by nurse observing a respiratory rate within normal range, 12 to 20 breaths per minute, and patient verbalizing ease or comfort in breathing. The others, assess and record respiratory rates, depth, rhythm, and effort every 30 to 60 minutes. Position patients in a high fowlers or semi-fowlers position to promote lung expansion. Encourage and assist patients, assist with deep breathing exercises every 1 to 2 hours. Monitor oxygen saturation using pulse oximetry. Administer oxygen therapy as prescribed. Notify the physician if signs of respiratory distress worsens or oxygen saturation drops below 90%. So basically, that is it. Now, the next one is patient has what? Edema at the lower abdomen. That is the left leg or swelling feet. Patient maintains stable vital signs within acceptable limits. That is edema. So you've seen a patient with edema of the abdomen, edema on the hand, facial edema, edema on the leg. This is how you write it. Patient has edema at the lower abdomen, or patient's left leg is swollen. Okay, or patient has swollen feet. This is how you write the problem. Patient has edema at the lower abdomen. Patient has edema at the left leg. Patient has edema at the right leg. Patient has edema at the right thigh. Patient has facial edema. This is how you write the problem. Okay, and then the strength. This is how you write the strength. Patients maintain stable vital signs within acceptable limits. Now let's look at the nursing diagnosis. Excess fluid volume related to disease process or compromised regulatory mechanism. Excess fluid volume related to disease process or compromised regulatory mechanism. No need to add these conditions, because we don't want to see medical terms in nursing diagnosis. Okay, so there is no need for you to add this. See, I've deleted it from there. So because we don't want to see the medical terms in the nursing diagnosis. So excess fluid volume related to disease process. Okay, excess fluid volume related to disease process. Excess fluid volume related to disease process or compromised regulatory mechanism. Objective/outcome criteria: patient fluid retention or swelling or edema will reduce within 48 hours, as evidenced by nurse observing decreased swelling, improved abdominal girth, stable weight, and normal urine output. Okay, you see over here, if you write this very problem, edema, your goal will be goal partially met, definitely. Okay, so patient fluid retention or patient swelling or edema would reduce within 48 hours, as evidenced by nurse observing decreased swelling, improved abdominal girth, stable weight, normal urine output. Assess and monitor vital signs, especially blood pressure and heart rates, every 4 hours. Measure and record intake and output straightly every shift. Monitor daily weight at the same time each morning. Assess for the extent and location of edema. Elevate swollen limbs when resting to promote venous return. Administer prescribed diuretics and monitor for response and side effects. You see how nice it is. Then you convert all to past tense for the intervention. Then the same thing. You see over here, 48 hours. So when you add 48 hours to this time, you are going, the date now will change to 17. So because 48 is 2 days. So you add the 2 days to this, you are going to get 17. So that's why the goal is partially met. Remember, that's why the goal is partially met. And these are the kinds of problems that when you write, you are only going to be able to deal with goal partially met or going to have goal partially met. Is that okay? Now let's look at this problem. Patient complain of general body weakness or body weakness. This is how you write it. Activity intolerance related to disease process. Activity intolerance related to disease process. Don't write activity intolerance. Remember that activity intolerance is representing the patient has general body weakness. So the mistake I see you people make is you write activity intolerance related to general body weakness. It's wrong. It's like you've related activity intolerance again to activity intolerance. Because the first part of your nursing diagnosis representing the problem you've written. So it's activity intolerance related to disease process. You can write activity intolerance. In fact, the activity intolerance is representing the general body weakness there in the nursing diagnosis. Okay, so activity intolerance. What is causing the activity intolerance? The disease the person is having, the disease process. Okay, good. Now, you see this one too, if you write a problem like this, general body weakness, you can't solve it within the exams period. So it will definitely be go partially met. So you see patient tolerance to activity would improve within 12 hours, as evidenced by if it is 12 hours, then I think here would rather be, it will be PM, right? If I'm doing 12 hours, then I think I changed it later on. Initially, I made it 72 hours, but I think later I changed it to 12 hours. So it's going to be PM. Do you agree? Am I right? Is my mathematics good? You agree with me? If it is 12 hours here, then we will maintain the time and make here PM. All right, that is fine. That's fine. Okay, so patient tolerance to activity will improve. Look at the word I used, though. Don't say activity level will be restored, though. Don't use restore. Patient tolerance to activity would improve. Patient tolerance to activity will improve within 12 hours, as evidenced by nurse observing patients perform basic tasks like setting up, walking short distance with minimal or no symptoms of fatigue or breathlessness. Okay, good. So assess patient's level of activity, monitor vital signs, encourage energy conservation techniques, resting between tasks and all that. Assist patients with mobility tasks, collaborate with physiotherapists or occupational therapists for graded activity. Educate patients on signs of exertion when to stop activity. Then you add the 12 hours to this time. You get 8 o'clock p.m. You write STN, then you sign under it. Okay. The last one is the loss of appetite. The loss of appetite, you can do rates for imbalanced nutrition, less than body requirements. Okay, the loss of appetite, rates for imbalanced nutrition, less than body requirements related to disease process. Don't write rates for imbalanced nutrition into brackets less than body requirements related to loss of appetite. Because mostly what I observe is this, you've already written the loss of appetite as the problem. So if you are coming to the nursing diagnosis, the first part of the diagnosis you are writing is representing the loss of appetite. So you can't go and relate it again to the problem you've written. So rates for imbalanced nutrition into bracket less than body requirements related to disease process. Okay, related to disease process. Then patient's appetite level would improve. Patient's appetite level would improve. Okay, let's say within 20 minutes, as evidenced by nurse observing patients eating 70 to 80% of meals served, and patient verbalizing that his appetite has improved. Okay, that's how you write it. So the loss of appetite. Please listen again. So you write rates for imbalanced nutrition into bracket less than body requirements related to disease process. Then now the objective stroke outcome criteria, patient's appetite level would improve within, let's say you can do within 12 hours, or let's do within 24 hours. Patient's appetite level would improve within 24 hours, as evidenced by nurse observing patients eating 70 to 80% of meals served, and patient verbalizing that his appetite has improved. Now, the others, assess patient's appetite. Okay, remove all nauseating articles from patient bedside before feeding. Serve patient food attractively. Is that okay? Encourage adequate intake of fluids. Okay, encourage adequate intake of fluids. Plan patient diet with family and dietitian. Plan patient diet with family and dietitian. Educate patients on the importance of adequate nutrition. Educate patients on the importance of adequate nutrition. Educate patients. Assess patients' nutritional status. Assess patients' nutritional status. Assess patients' nutritional status. Assess patients' nutritional status. Is that okay? Simple as that. Okay. This brings us to the end of the nursing care plan. This brings us to the end of the nursing care plan. Any questions? This is the point you ask all your questions on what we've done for today for the nursing care plan. This is the point you ask all your questions. So please ask all your questions.
Hello, sir.
Yes, please. I'm listening.
I hope you give us all the slides.
Come again?
Please, I hope you give us all the slides.
Yes. In fact, I won't give you the slide, but I will send you the video.
Okay.
Yes, I'll send you the video. The video has everything, right?
Yes, sir.
Yes, the video has everything.
Okay. Thank you.
Yes, excellent. So now I think we can start with the practicals. Can I start with the practicals?
Yes, you can.